Welcome to Putting Out the Brain on Fire Session 4. The subtitle of this session is Treating the Brain on Fire 2. Last month we did Treating the Brain on Fire 1. Treating the Brain on Fire 2 is Balancing the Brain with Hands-on Neurological Corrections. And so we're going to, this month, tie everything together we've done, put it all together, adding the final piece, the structural piece, or structural/neurological piece on what to do to keep the brain operating at its best optimal function. And we're going to do that over the period of the next couple of days. And there's a lot going on right now. In fact, at noon, the seminar starts. At 12:30, Duke football starts. And at 1 o'clock, Duke basketball starts. So if they're conflicting with each other, I figure they could conflict with me. So we are going to have a high sports tolerance for the first half of the day today, and then we'll forget about that. But so putting out the brain on fire is comprehensive treatment, assessment and treatment of inflammation and overexcitation in the brain. And that's the sort of overview of what we're looking at. The brain on fire, the brain is our most complex and important organ. When fanned by inflammatory inflammation and excess excitatory activity, brain neurons become overstimulated to the point of exhaustion and even cell death, the so-called brain on fire. What is a brain on fire? It's excess neuron firing and or neural inflammation leading to further neuron misfiring, neurological signs and symptoms, and even neuron cell death, which leads to then, of course, the process of neurodegeneration. So sessions 1 and 2 achieve an understanding of how to approach the immune system and inflammation through AK testing. These tools are necessary for applying the clinical principles of brain evaluation and treatment covered in sessions 3 and 4. So you'd be amazed at the changes that can be made using your hands, nutritional tools, and your own brains. Session 3, we talked about last month, the chemical influences inside the brain, looking more specifically at inflammatory activity and neurotransmitter activity that affected brain activity. And then this weekend, session 4, we're going to talk about the structural patterns that create and perpetuate the brain on fire. And we'll look at different structural patterns, particularly the ones we'll focus on are the brain on fire patterns from deafferentation, lack of sensory activity based on, or maybe sometimes excess afferentation, based on patterns of centering the spine. You know, the spine can move in 3 directions, 3 planes of motion: flexion, extension, lateral flexion, and rotation. And then we're going to talk about the cerebellum and the source of input into the cerebellum, and we're going to use semicircular canal activity. You know, we have 3 semicircular canals on each side. But we'll use semicircular canal assessment to try to identify if there is a problem coming into the body structurally or neurologically that needs to be tended to in a certain location of the body. And the semicircular canals, of course, are a balance mechanism, but they fire according to different muscle inputs and different neurological inputs. And if there's a problem in one particular quadrant of the body, it will sometimes affect the semicircular canal firing, which will then affect the cerebellum firing, which will then affect the cortical firing. And so this becomes an issue which we'll be spending some time on later today and tomorrow. And then there could be problems with the immune system. Now, I know we already talked about the immune system and talked about inflammation, but you could have a thymus problem. You could have a spleen problem. And we talked about these before in earlier sessions and talked about in session 1 how the thymus and the spleen impacted the mesencephalon. It's something we talked about in the QA program. But there still could be leftover levels of thymus or spleen activity that we need to treat in order to put out the brain on fire even after we've done previous procedures. And as the body unfolds, sometimes one thing shows more importance than another. There's a hierarchy, and that's what the QA protocol is all about, and that's what the protocol putting out the brain on fire is all about as well. So we're also going to put at the bottom TMJ. Now, TMJ should have been corrected already, but there are sometimes residual TMJ issues, and I just put it at the bottom, but we're really not even going to talk about it. But when we get through this weekend and you go through all the things we talked about this weekend, and you can't find anything else to turn off the pathway that we'll be identifying as the problem, then you can still always look at the TMJ. It can be very adaptive, the TMJ, and hide and then show up later. But it's not a big deal. We'll just put it at the end because it does sometimes show up when nothing else does. So session 4, you will learn structural and visceral imbalances negatively impact the brain and interfere with normal function. Now, in session 1, we already talked about some of the visceral imbalances, but we're going to add to that again a little bit more today. Using information from sessions 1, 2, and 3, you'll learn organized neurological challenges to identify the specific needs of each patient, including centering the spine and endocrine patterns like we talked about previously, and also the vestibular patterns of the semicircular canals, as well as some other things. So during this session of session 4, you'll develop the skills necessary to correlate structural, chemical, and mental assessments and therapies toward achieving optimal neurological function to your patients. So this is where we kind of take all the pieces and put them together, and we can see how the model that Dr. gave us, the equilateral triangle, triad of health, structural, chemical, mental activity, all interrelating will become more apparent as we go on through the weekend. So if you want to fly a plane, first thing you have to do, you have to learn to land. Because you don't want to take off if you don't know how to land, right? So the first thing you have to do is learn how to land. So in session 1, we kind of taught how to land. What that means is after all the things we talked about in sessions 2, 3, and 4, then we're going to put on what we did in session 1. We're going to put those into play, and we'll talk about that a little bit today. Then you have to learn how to take off. That was what we did in session 2, and this was monitoring for patterns of right brain and left brain activity. Looking at endocrine and immune function and nutritional dysfunction that could affect right brain and left brain activity. So then finally, once you've taken off and you land, you want to be able to fly somewhere. So how to fly, sessions 3 and 4. So we have this pattern. We taught this these procedures that we're talking about. We didn't teach them in the same order that we do them. We taught them in an order that was best for teaching, but we're going to put them together in order where we do the things we do in session 2 first, then 3 and 4, and then 1. So we must always correct switching patterns first, including injuries such as injury recall technique, or NSB if there's an acute situation of pain, set point in acute pain, and also the K27 for switching, and highway patterns for switching, and also small intestine patterns for switching, what we call switching. If we're going to treat the brain, we need to do and assess the brain, we need to get these switching patterns out so we get a clear picture of what's going on in the central nervous system. When we correct the right brain, left brain procedures that we talked about in Brain on Fire session 2, this will correct some of the brain findings. So we do this one first. In other words, we'll sometimes kill 2 birds with 1 stone, or that type of thing. If we correct the right brain, left brain factors, after we do the switching, then we correct right brain, left brain factors, a bunch of other stuff might clear itself out. We may not have to go in as great a depth with the patient. And what's left then, or if there is no right brain, left brain challenge like we've taught in session 2, which we'll review today, then we'll go on and do the things we taught in session 3 and session 4. And then when we're done with that, brain on fire session 1 procedures, which are really looking at the TMJ as a diagnostic indicator really of the mesencephalon activity, these will follow procedures from session 3 and session 4. So what we're really looking at in these procedures is pretty much everything from the brainstem up to the cortex in relative to the interactions. And the procedures put together over a long period of time to decide what to do first, next, and last, just like QA is what to do first, next, and last. Well, what to do first, next, and last when you have a patient who presents with brain symptoms. Now this weekend, today, later on, we are going to have a patient come. It's actually a patient from the office who couldn't get in to see me for an appointment, so I said, if you come, you can be my demonstration person. She agreed to do that. Twist her arm a little bit. But she's a very nice lady. She's going to come about 3. We'll have to take a break after 3 o'clock or something like that, and she'll be here. And we'll talk about that a little bit more later. So we're actually going to take someone who actually has some issues, and we've been working on, and we'll have that as part of the program, something we usually don't do. We usually use people from the audience, but this is going to work out good for her and good for us as well. So a little different take this time. So we're going to look at sessions 2 first, sessions 3 and 4 second, and then session 1 last in the order that we're treating these patients. Well, what are the common problems that respond to the brain on fire series topics? Well, memory problems. This patient we'll see later has memory problems. Anxiety, depression, bipolar disorder, which is bipolar disorders like manic depression. Pain and recurrent pain. A lot of pain is perpetuated because the brain is on fire and the pathways associated with the brain on fire. The neuron pathways are firing, not allowing the pain to not be perceived, or once the pain is perceived, accentuating the pain perception. And learning issues, visual changes, sleep issues, mental fatigue or brain fog, or sometimes people call it my brain is fuzzy. I don't know how many people have you tell you that my brain is fuzzy. Named and unnamed autoimmune diseases, including multiple sclerosis and Parkinson's disease and who knows what else. And recurrent visceral and structural faults. One of the biggest problems I've had in my entire career, maybe some of you had as well, is the patient comes in with the ileocecal valve and can never seem to get it to stay put. Well, the ileocecal valve can be associated with a problem in the autonomic nervous system descending from a brain imbalance. And we can have these issues that take place for any digestive system, any cardiovascular problem, any type of autonomic problem anywhere, can be associated with imbalance in brain activity and some pathways firing from the brain down into the brainstem, creating this autonomic perpetual problem, which you treat locally, but it doesn't respond because the problems are arising in the brain. All these things you can treat that have local issues. You could treat structural faults and recurrent problems. You can treat the visual changes and treat the eyes, so on and so forth. You can treat the local area of the pain, but you treat all these local issues and the patient does better. A lot of times we fix them. But when they recur, they don't do as well as they should. We have to look higher and see if there's an issue in the brain misfiring. So there are 3 factors. Actually, we can kind of simplify this a little bit. 3 basic factors we're looking at in patients who have brain symptoms. First one is imbalance in neurotransmitters. Second one is inflammatory activity in the brain, which arises from inflammatory activity in the general system. And the third one then we'll talk about this weekend, which is why it's highlighted, is neurological stimulation. You want to have the right amount of neurological stimulation, but not too much to keep the brain neurons healthy. So in the brain on fire with excess, we can get excess brain activity. We have overfiring of neurons, even to the point of fatigue and exhaustion, but this can come from excess excitatory neurotransmitter activity. So we may have neurotransmitter imbalances. Now, the truth is, I saw a patient this week who had, for a number of reasons which I won't go into, had been on has chronic pain. I'd seen her a couple of times. This was the second or third time I saw her. But her pain got accentuated to the point where she had been taking some pain medications, and they tripled the level of pain medications. And this patient went from a pattern where her brain was being overstimulated, and she showed weakening response on aspartate and glutamate, aspartic acid and glutamic acid, originally, to when it was not inappropriate to do this to her. I won't go into details, but to when the point where she had this massive increase of the painkillers. It so suppressed her brain that all of a sudden now, GABA, gamma-butyric acid, and some of her other meds which suppressed that perception of the brain, which also made her just spacey and groggy, but they became the culprit. And so we were checking her brain and checking her supraspinatus, as we'll talk about later. It was GABA that weakened her. Now, GABA is an inhibitory neurotransmitter. So here we talk about excess excitatory neurotransmitters, but it could be, the same pattern could be true for any brain problem in patients who are ODing maybe, or for some other reason have excess inhibitory neurological activity. You'll find that as well. It's just far less common, and you don't think in terms of inhibiting the brain and causing the brain to be on fire, because it kind of dampens the neurological issues. But any neurotransmitter could be involved. So we're really mostly looking at the brain on fire and excitatory activity, but there could be any neurotransmitter imbalance. Inflammatory activity is going to arise from cytokines anywhere in the body, and the cytokines could arise most commonly from the GI tract, but they could be really coming from anywhere. And they could be coming from an injury, or they could be coming from infection somewhere. So the sinus infection or kidney infection or bladder infection or anything, prostate infection, all these things could cause cytokine activity as well. We think that the most common place is in the GI tract for these to arise, and it is, but it could come from anywhere. So we have the cytokine imbalances, and the cytokines cross the blood-brain barrier and get in, they stimulate microglial cells, which are like macrophages inside the brain. And these microglial cells start to create inflammatory chemicals inside the brain, and they create potentially damaging effects, but certainly perpetuating firing of different pathways. And then the other thing we're focusing on this week is the altered sensory activity. You have too much or not enough sensory activity. You could have overactivity or underactivity. You could have too much excitatory activity. You could have not enough inhibitory activity, and combinations of the two. So this altered sensory activity is really what we're looking at to try to balance the brain. And if you have a person who's got a gait problem, and they're going like this every day with more zigs and zags, you can try to put the brain on fire, but the nervous pathways that are being fired by that asymmetry and structure are going to turn the pattern right back on again. So there's this structural component that's very important. So the 3 factors in brain on fire: 1, neurotransmitters, usually excess excitatory neurotransmitters. with deficient inhibitory neurotransmitters. And so what we're going to look at then is the inhibitory neurotransmitters, or whatever neurotransmitters we need, nutritional factors, and we supply the nutritional factors. Now, usually, within a couple of visits of identifying neurotransmitter imbalances, you've pretty much got the patient on the nutrition they need for their neurotransmitters. This one, you can handle it, and maybe you have to tweak it. Maybe the patient shows one neurotransmitter one time, and maybe another time they show another neurotransmitter imbalance, maybe a third time a third one, but usually it doesn't go too far beyond that, unless something changes in their diet or something else. But this one kind of resolves faster when you get the patient on the basic nutrients they need, and then it doesn't recur. The second one, the inflammatory process, the cytokines and their sources, well, this one changes, and this one we have to keep on top of. And there's no way that I know of to keep on top of the patient's changing of cytokine imbalances that are affecting the brain, or affecting any tissue in their body for that matter. These inflammatory chemicals, or some are cytokines or anti-inflammatory. But the cytokine imbalances, we have to look at the cytokines and their sources, and look at them. We find out where is the source of the cytokines. Is it coming from the GI tract, for example, which is so common? Is it coming from the small intestine from an allergy? Is it coming from the large intestine from some imbalanced microbiota in the large intestine, or what we call dysbiosis in the past? So we have to look at the sources and treat the sources, but we also then have to look at the nutrients for the cytokine metabolism to support the anti-inflammatory activity. Now, because the immune system has the adaptive immune system operates on a 5 to 7 day cycle, that's why a cold lasts about a week. It takes about a week for the immune system to crank up to that 7 day full pour of activity, and then it can knock out the cold. Well, when the adaptive immune system goes through a cycle, it goes through a cycle, and then it cycles again, and it keeps changing. What you find is that patients' immune system issues, especially if they have long-standing chronic problems, they tend to last longer, and much longer than the neurotransmitter imbalances, and you have to keep tweaking them and changing them. And you'll see imbalances maybe in a Th1 pathway, a Th2 pathway, and then you treat it, and all of a sudden next time you have a Th2 pathway imbalance with a Th1 pathway, and then you treat that, and maybe all of a sudden you find an innate immune system imbalance with cytokines. But you have a method of identifying and staying with it. And if you follow the patient from treatment to treatment, or month to month, or however often you see the patient, you'll see that after maybe 2 or 3 weeks, a lot of times the cytokine imbalances, if the patient isn't all better, will still be present, but they'll be different. The nutrition that supports that will be different, and you'll have to tweak what you're doing to the patient. So these neurotransmitter imbalances, these things are pretty easy to handle. The cytokine imbalances, you got to stay on top of them, and it's one of the things that makes people difficult to treat. People talk about how difficult Lyme disease is to treat, and it certainly is. And I haven't had a lot of experience with it, but I've had some experience with it. And one of the problems is that it keeps changing. So people are put on a regime for, say, Lyme disease or any chronic infection. You know, it might be Epstein-Barr virus, the old chronic fatigue syndrome, yuppie flu thing talked about in the 1980s. It might be something like that, and they go on a regime. But guess what? The immune system changes, and it goes to another level, usually better. But if you keep them on the same regime, they're not prepared to go to the next step. So we have to have a way of evaluating their immune system, and it's not following any particular pattern. We follow it through the process of what we do this time, and then maybe I see patients sometimes a little farther apart, so maybe I see them every 3 or 4 weeks, and after maybe 3 or 4 weeks, all of a sudden I'll reevaluate their immune system. It's different. It's just different until they level out and they're good. Now, the compounding factors are they could go out and eat something they're allergic to, either on purpose or by accident, and that throws the whole thing into a tizzy again. You got to not necessarily start all over, but you have to readapt the immune system's reactions. Some patients have nutrients that they need to support the immune system that are sort of constitutional in nature for them. They're foundational. They may have a genetic imbalance, and I suspect that a lot of patients that we see have genetic imbalances, especially with immune system problems. And they may have a genetic imbalance where they maybe just have excess tumor necrosis factor alpha activity, or excess interleukin-1 beta activity. These are inflammatory neurotransmitters. And so they got this excess, they got SNPs and they got the excess activity, and you got to figure out what you're going to have to put them on that negates that, and they're going to probably be on that forever. Or maybe they have a low functioning interleukin-10 synthesis, which is inhibitory to inflammatory activity and to allergic activity. And so maybe they have a low interleukin-10 pattern. And so what they need is, it may be because of a genetic thing, if they have a low interleukin-10 synthesis because they've got a SNP or two for the interleukin-10 synthesis, then you're going to put them on some nutrient that's going to support interleukin-10, whatever you find. Maybe it's green tea, or maybe it's resveratrol or something. You're going to put them on that, and they're probably going to be on it forever. It's constitutional, foundational for them, because that's the way they are. Now, you can do genetic testing. That's pretty cool, and it's fun. I do it once in a while, but not too often. But when I've done the genetic testing, it's explained a lot of things to me why patients could never get off a certain nutrient and maintain their condition, because it's genetic. Then there are other patients that have maybe the exact same nutrients, but they're just going through a phase. And those ones that are going through a phase, that'll shift. So you have some patients who you have maybe on certain foundational immune system support nutrients, and maybe they'll be on it from now. Maybe they're taking curcumin for the rest of their life, maybe. But other things will change until you get them stabilized. And so you have to kind of give and take the nutrients as the patient adapts, and we have a method of doing that we talked about in the last session, and we'll review again in this session. So this inflammatory process and the nutrients for cytokine modulation, these are the ones that are going to change a lot. Not so much the neurotransmitters once you get them set, but these cytokines are shifting a lot based on, first of all, the change in the patient's environment, patient's diet, patient's stress levels, but also they change according to just the immune system trying to evolve into its next level of higher function, get back towards normal when it's been sick. Then the third one, third of the 3 factors in brain on fire, this is the neurological stimulation or structural imbalances. This could be a need for more excitation or more inhibition. The question is what pathways? And this could be coming from autonomic or visceral effects, which is what we really talked about in Brain on Fire session 1. We'll review that again today. It could be from lateral flexion patterns where there's an endocrine imbalance and it creates an imbalance in the spine, and you're getting constant imbalance from the feedback from the center and the spine patterns from endocrine issues, or sometimes you could have a gait issue. There was like pituitary pineal patterns that we talked about in the quintessential applications course, where you see that the spine is off center from these higher level endocrine functions, and we have to address that to change so the person's not getting more zigs and zags as they walk every day, walk along. They balance their patterns of feedback 24 hours, well, however many hours a day they're on their feet. Then there are lesions that can take place from whether it be subluxation or fixation, structural lesions, or sometimes set point technique. By this time, we had already treated injuries for injury recall technique, so it probably wouldn't be injuries, but set point technique could still be present. And the area of or maybe a location quality memory technique, one of the old time history of injury that hasn't been corrected and is still active in the brain. These things keep perpetuating imbalances in neurological feedback, and we can address those issues as well. And we find those in where they are by challenging the semicircular canals, by putting the head in different positions to fire the semicircular canals and seeing if it negates any of the issues the patient's having. And when we find that, then we'll be able to assess where the problem is and then what to do for it when we find where it is. And then immune system, as we talked about before, the thymus and the spleen in particular, will have inhibitory effects, especially into the mesencephalon on the same side of the thymus being, the reflex of the thymus being on the right and the spleen being on the left and its reflex being on the left. The thymus on the right will affect inhibitory activity into the right mesencephalon, and the spleen on the left will inhibit the left mesencephalon if it's overfiring. So then TMJ could also be an issue, as we mentioned. So with the three factors in the brain on fire patients, the neurotransmitters, inflammation, and neurological stimulation, we always want to fix injuries first. IRT for old or new injuries, NSB, nociceptor stimulation blocking technique for acute injuries, and set point technique for either old or acute injuries, but typically the set point technique is not something we're going to look at unless the patient has an acute injury at this very first step of development here of the problem. I have some athletes and they get dinged up, in pretty good shape, and they get dinged up, and they come in, and sometimes I have a hockey player, he gets hit with a puck. He's got this big thing on his arm or something, and he responds really well to set point technique. I mean, because it's acute injury, and it doesn't show IRT, but it shows set point, he always responds really well to it. So if it's acute injury, you still might want to be doing set point technique. You see, instead of just NSBs, the person could have acute injury and not have NSB, but just have set point, not have IRT, but just have set point. So when there's acute injury, that's why I put SP for set point here. But we always want to fix the injuries first. When there's input coming from injury, the nociception comes up on that side of the body and influences on the opposite side of the brain, as we know. But the muscle imbalances associated with that injury, the withdrawal reflexes, the flexor reflex afferent pathways, that we used to call them the flexor withdrawal reflexes and the cross extensor reflexes. But those muscle imbalances, especially on the side of the injury, the flexor withdrawal and inhibition of extensor, these create muscle imbalances which are also registered in the cerebellum and transmitted up into the cortex on the opposite side as well as into the brainstem. But these things that everyone overlooks about injuries are the fact that there are muscle imbalances that can perpetuate problems and perpetuate neurological imbalances from the injury, not just the pain, but the muscle imbalances which create instability and also alter feedback and cause the cerebellum to have to adapt. And so this mechanical or structural input from neurological activity from pain or injury is important to negate because it drives one side of the cerebellum across into the opposite mesencephalon and up into the cortex on the other side. Now, some of you haven't been in this class before, and I'm going over some of this stuff fast, but this is all stuff we talked about in previous sessions, and we have questions about it. Some we'll talk about later, but a lot of it's in the QA class as well. But this is the idea that you could have an injury, and it's going to alter the input into the cerebellum on one side, the midbrain and mesencephalon on the other side, into the cortex on the other side, if there's an adaptation to that injury. Not so much just the pain, but the neuromuscular response, the withdrawal reaction. So if you put your hand on the brain, you're walking around like this. Now, you may be walking around like this, but there's this muscle tendency, muscle imbalance, you're walking around with all day long. This is going to be driving pathway, which is going to alter the perceptions of right and left brain activity. And if you don't first get that injury out of the way, and the muscle, not just the nociception, but the muscular pattern as well, then it's going to skew what you find when you start to evaluate right brain and left brain activity. And one of the things that you'll see, and I'm a chiropractic neurologist, and in chiropractic neurology, some of the most difficult problems are when you find patterns that would be like a cortex on one side and a cerebellum on the same side. Now, the cortex on the left really drives the cerebellum on the right. The cerebellum on the right drives the cortex on the left and vice versa. But what happens is you get the patients who show cortex problems on the left and cerebellum problems on the left, and these are very difficult. Well, in my experience from what I've seen is when you find these mixed up patterns, these are patients who are really, their nervous system's responding to too many masters. You know, it's like responding to maybe an injury on one side of the body, another injury on the other side of the body. Maybe they've had dental work on one side of the body. That can confuse the heck out of things because the dental feedback is so powerful into the brainstem and cerebellum first brainstem. And then maybe they've got a liver problem, which being on one side and having a reflex on one side can drive the other side. And they got these confused levels of things. But if you don't fix the injuries first, then all the rest of it's going to be skewed by the injuries, by creating, I mean, people have multiple injuries sometimes in their history. And they have maybe presenting with multiple acute injuries who've been in an accident. If you don't fix that, your findings of right brain, left brain are going to be skewed. It's like trying to find your way through a jungle, you know, to get to a clearing, and it's all nothing but woods. You can't see where you're going. And you're just running up against one obstacle and another. You got to chop down this vine and walk around this tree and all that kind of thing. There's a lion. He's walking through a jungle. He's feeling real proud of himself. He went up to the Thompson's gazelle. He said, "Thompson's gazelle, who's the king of the jungle?" And the gazelle said, "Well, you are, Mr. Lion." He walked a little farther. He came across a monkey. He said, "Monkey, who's the king of the jungle?" He said, "Well, you are, Mr. Lion." He walked a little farther, came into a clearing. There was an elephant, big, huge elephant in the clearing. He said, "Elephant, who's the king of the jungle?" The elephant walked over to him, wrapped his trunk around his waist, picked him up, and then pounded him back and forth between a couple trees on the side of the clearing, and pounded him 4 or 5 times down like that with his whole body on the middle of the clearing, and then stomped off into the distance and put all 4 paws on him as he walked out of the clearing. The lion lifted his head and looked up and said to the elephant, "You didn't have to get so mad just because you didn't know the right answer." Well, sometimes we're kind of trying to find our way through the jungle of the patient's findings to get a handle on what's going on, and the injuries are the biggest thing that will interfere with us finding that, creating the smoke screens or the adaptations or whatever. So we've got to fix the injuries first. Then similarly, we've got to correct switching. Switching patterns, neurological disorganization will create imbalances that show right-left issues, and the switching factors we're going to look at are the K27 patterns, which could be structural, could be a K27 pattern related to a cranial fault or TMJ fault, but most cranial faults and TMJ faults, are secondary to immune system problems. So we could have an immune system issue that was important enough it needed to be fixed pretty much early on in the patient, thymus or spleen I'm talking about in particular, sometimes the lower sternum, which relates to chemical sensitivities or heavy metals. But these things could be at the top of what we see, and they create a switching, so we would get inaccurate assessment of the right and left brain activity if we didn't fix those first. So we fix the switching, K27 patterns, to the hyoid, and the hyoid sometimes is one of the very first things you're going to fix on a person if they have a problem with folic acid. Now, there will be a hyoid imbalance that Dr. Gart found back in the 1970s when there's a need for folic acid. You challenge the hyoid left to right or right to left, or you could rotate it or you could tilt it, but most commonly it's a lateral challenge to the hyoid. And that lateral challenge to the hyoid, Dr. Gart found would be related to one of three things: folic acid, the thymus gland, or a TMJ issue, mechanical TMJ issue. Folic acid is one of the most common things you'll find in patients who have chronic problems or have brain problems because it's such an important nutrient for neurotransmitter activity, especially the activated form of folic acid, 5-methyltetrahydrofolate. And when you have 5-MTHF deficiency and patients don't know it, then nothing else is going to get better until you give them the 5-MTHF. And if you don't start with that, you're just painting over rust, causing the body to go from one adaptation to another, and you're just sort of pushing the problem around. Now, I know there's some people that say, oh, you should never treat the nutrition until you balance the brain, but I would say there's some cases that might be true, but the body will tell you what to do. But in most cases, if you don't give the nutrients for neurotransmitter activity, you're just going to push the problem around. You're not going to fix it. So folic acid becomes one of the most important nutrients. I started writing a paper one time called Folic Acid, the Most Important Nutrient in the Body, and I never got finished with it because it was going to be too long a paper of all the different uses for it. And this was before even we had 5-methyltetrahydrofolate available, the activated form of folic acid. So you'll find that with a hyoid a lot of times at the very beginning in patients, especially those with brain issues and especially those who have difficult issues. Then we have to look at the small intestine. Small intestine, whether it be food allergy reaction, bad fat reaction, QA step 5, food allergy reaction, QA step 6, or whether it be a problem with small intestine from a patient having too much carbohydrate ingestion and what would appear to be small intestine bacterial overgrowth, or SIBO, which is QA step 23 and CD, those issues will create a distortion of our findings of right brain, left brain activity as well, if they're present and they need to be fixed first. So we can assess for small intestine function first as well, and that's what we're going to do as we go through treating patients. Then we've got those switching factors in the injuries, which can also create a switching pattern. I mean, we don't talk about the injuries as being switching factors, but they are. We talk about them as a separate thing, but they will create a switching or a distortion of right brain, left brain findings. Then we go to what we taught in Brain on Fire session 2, and this is looking at right brain, left brain activity. And we have a weak muscle, and we have the patient hum or count, and we test in 3 ways. And we see if we get a right brain strengthening or a left brain strengthening. And if we do, then we assess that for endocrine function, immune function, or nutritional imbalance that are related to right brain, left brain. That was all of Brain on Fire session 2. When we get that done, we have cleared the way for a clear evaluation of what we're going to see looking at the neurological function of the brain using the supraspinatus as an indicator. Supraspinatus is a muscle that Dr. Gart found to be related to the brain, and it is. And it will be present on the side of the problem, having cleared the switching factors and the other things we just talked about first. It will be present on the side of the problem where the brain is. And so what you're going to do is you're going to find the supraspinatus, a number of ways we can do it. We'll talk about it before and we'll review it again. And then you have to, again, fix the injuries, K27 patterns. K27 patterns including the immune system if there's a cranial or TMJ problem. Tooth problems, which can create a cranial or TMJ problem, and also hyoid. These are patterns that we pick up with the 3 different types of K27's therapy localization: right to right, left to left, cross right to left and left to right, and then dorsal cross right to left or left to right. Then small intestine. Then again, we correct the right left brain activity for humming and counting, as in did in session 2. Then we test the supraspinatus. And we can find out then if there are issues, which we'll review again in a few minutes. Then we balance the neurotransmitters, correct the inflammation, and then focus on the structural therapies, which could be subluxation, fixation, or set point technique even. Again, you should not have an IRT pattern left by this time, but you could. So when would you deviate from the QA protocol to perform the procedures discussed this weekend and in the entire Brain on Fire seminar series? Because this takes a QA protocol, which is still the QA protocol and is still the best way to practice on patients, but there are certain times when you deviate from it. And when you would do it is when the patient's history and or symptoms suggest that the brain itself is the primary origin of symptoms and findings. And then you have to kind of shift things around. And the QA protocol, when the brain is itself the organ of dysfunction, you have to shift things around and clear these switching factors and so on first. When we're dealing with a Brain on Fire patient, we alter the QA protocol, moving QA step 9, the switching factors, up ahead of QA step 5 and 6, which are bad fats and allergies, mostly small intestine problems. And we always check injuries first under any circumstances. We move QA step 9 instead of QA 5, ahead of QA 5 and 6, so that by correcting switching in QA 9, we can clear the way for proper TMJ assessment. And we may correct the tooth and TMJ muscle patterns and correct the hyoid. And either of which may interfere with TMJ challenge procedures, which we're going to do if we're looking for small intestine dysfunction or if we're looking for any other autonomic dysfunction later on at the end of our treating of the patient. In Brain on Fire session 4, we will start with the weakness induced by neurotransmitters and cytokine challenges to the brain Chapman's reflexes. So we're going to take those cytokine challenges. We've already talked about how to treat them. We're going to take those neurotransmitter challenges. We already talked about how to treat them nutritionally. Now we're going to find out, is there a structural or neurological component that's necessary to eliminate the pathways which are perpetuating the problem in the brain. And so we test various indicators of neurological imbalances to identify what negates the challenge weakness of the supraspinatus Chapman's reflex. So we look at neurotransmitters using the supraspinatus brain Chapman's reflexes to assess. Let's just review that. So we're first going to find a supraspinatus. So we're going to do this in a workshop again because we're going to workshop during the weekend. We have to kind of know where each of us stands. So we're going to do the workshops and some of these things, which will be a review. But we're going to, when we find out what brain reflex is involved, we're going to use that Chapman's reflex. And the nature of the neurotransmitter imbalances may be identified by challenging the brain Chapman reflexes with the excitatory neurotransmitters looking for a weakness. So say the problem is on the right, we're going to touch the Chapman's reflex for either the brain or what I call the cortex, the one that's an inch higher on the clavicle. You touch it, and then you start to challenge a patient with different neurotransmitters. Usually you start with the excitatory ones in the brain on fire, glutamate, aspartate, sometimes dopamine, but any others could be, but those are the ones you start with. Could be norepinephrine, or epinephrine, the person is high stress. But you find out what neurotransmitter substance causes the brain Chapman's reflex to therapy localize. It's pretty straightforward. That neurotransmitter that causes the brain Chapman's reflex to TL suggests an excess of that neurotransmitter. It could be histamine, especially if there are allergies. Further assessment includes identifying a second neurotransmitter, often an inhibitory neurotransmitter, that negates the weakness created by the first neurotransmitter. So it might be GABA, the most important neurotransmitter in the central nervous system, 5-hydroxytryptophan, 5-HT, which is serotonin, dopamine, or others, could be others. Then what we have to do is we have to find the nutritional factors, but really any neurotransmitter may cause a positive TL to the brain Chapman's reflex, and any other neurotransmitter may negate that weakness. And when we find that, our next thing to do is to treat the source of the neurotransmitter imbalance. Involves identifying what the neurotransmitter negates the weakness, and then identifying the nutrients that support the strength of the neurotransmitter and negates the weakness. Does that make sense? I'm kind of whipping through this, I know, but it's sort of a review. Okay? I mean, it's kind of straightforward. Find out what weakens, find out what strengthens. Okay, now you find out what strengthens. How does the body make that? Make it. Same thing through with inflammation. It's the same basic thing. You look for cytokine imbalances. The nature of the inflammation affecting the brain may be identified by challenging the brain Chapman's reflexes with cytokines looking for weaknesses. Th1 induced weaknesses, Th2 induced weaknesses, Th17, which is autoimmune problem, or innate immune system if you don't find the other ones. Then to see how the cytokine will cause the brain Chapman's reflex to therapy localize, suggesting an excess of that cytokine. I should say cytokine. And again, Th1, Th2, or Th17, or sometimes innate immune system cytokines. And then further assessment involves identifying a second cytokine, usually an anti-inflammatory one, that negates the weakness created by the first cytokine. So interleukin 10, most common one, interleukin 2 plus TGF-beta, these together, when these two are present together, they will cause a naive T cell to become a T regulatory cell, which basically has inhibitory effects on inflammatory activity. So these two are inhibitory. And then cytokines, sometimes they're just imbalances in the innate immune system cytokines, and we might find one of those that would, if we found an innate immune system cytokine that weakened, we find another innate immune system cytokine sometimes that would negate the weakness. In fact, any cytokine can cause a positive TL to the brain CR, and any other cytokine can negate that weakness. Treating the source of inflammation in the brain involves identifying what cytokines negate the weakness, and then identifying the nutrients that support the cytokine, the strengthening cytokine, and also that nutrient will also negate the weakness. So again, it's pretty straightforward. Find out what weakens, find out what strengthens, find out the nutrient that supports what strengthens. Then the final one, neurological stimulation. Assessment of the neurological factors involves identifying a pattern that negates the weakness created by the cytokine and or the neurotransmitter. We can use autonomic challenges, the eyes and the TMJ challenges that we talked about in Brain on Fire Session 1. Autonomic challenges, near vision, far vision, with the eyes, looking at a distant object, looking at your nose, or holding the hand in front of the nose and looking at a close-up object. Challenging for the distant sympathetic, up close for parasympathetic. If we find that the body needs sympathetic or parasympathetic activity, if that negates the cytokine challenge or the neurotransmitter challenge, that tells us there's somewhere in the body that needs more of whatever strengthened, needs more sympathetic activity. So you've got tumor-necrosis factor alpha that causes therapy localized to the right brain Chapman's reflex. And then you find that looking at a distant object negates it. It means that a source, if not the source, of this cytokine stress on the brain is coming from some organ that needs more sympathetic activity. It's got to have more sympathetic activity. When you fix that organ, it will reduce the source of the cytokines into the brain. Could be parasympathetic. So then that would show a person would look up close. We can also use similar challenges when we find out what's challenging the cytokine. So we've got a cytokine therapy localization or a neurotransmitter therapy localization to the brain Chapman's reflex. We then can do the near fire for autonomic. We can also do jaw protruded and jaw retruded. Jaw retruded is like the fight or flee reaction. It's autonomic sympathetic. Sticking the jaw forward is like when you kind of relax and lay back, like parasympathetic. So if you stick the jaw forward and it negates the cytokine and neurotransmitter challenge, some organ needs more parasympathetic activity. And the fact that it doesn't have enough parasympathetic activity is causing it to generate something about that dysfunction to generate cytokines that are causing the brain to be on fire, or throw off neurotransmitters that are causing the brain on fire. And so we do these challenges, sympathetic and parasympathetic, and we find one that we talked about in Session 1. What we're testing against now is we're testing against what stresses the brain. So we're getting more specific than we were in Session 1. Something stressing the right brain. Maybe it's glutamate, and maybe it's TNF-alpha, maybe both of them. And you look off in the distance, and it doesn't strengthen. You look up close, it doesn't negate the weakness. You stick the jaw forward, it doesn't negate the weakness. You pull the jaw back, it does negate the weakness. Pulling the jaw back is what type of input in the nervous system? Sympathetic, right? Fight or flight, pull the jaw back, set your jaw, and go into battle. So pull the jaw back negates the weakness. Now you have to find an organ that needs more sympathetic activity. And you do that by challenging what the viscerally referred pain is. You can just pinch the different VRPs until you find one that negates the challenge. Now you found an organ that's generating the issue. It's usually small intestine if they've had allergy reaction, or large intestine if they've got imbalanced microbiota in the gut. But it could be any organ. And then you have to treat that organ. So that's the first thing. This is what we're doing, is taking Session 1 now and updating it and bringing it into using the patterns of Session 1 relative to autonomic dysfunction in an organ causing imbalances which affect the brain. And that's what happens. This is a part that people look at, but they don't look at specifically, look at very, very generally. We can find out specifically what part of the gut is involved. Or is it the liver? Or is it the sinuses? Maybe they got sinus allergies and that's affecting cytokines that are affecting the brain, or whatever. We can find out. The second thing we do is we got a cytokine, maybe it's coprofactor alpha touching the right brain CR, and the second thing is that causes weakness, so we want to find out, are there structural patterns that negate that weakness? We put the patient in lateral flexion patterns, lateral flexion left, lateral flexion right, and see if that negates the weakness. If it doesn't, then we go on, but if it does, then we have to identify an endocrine pattern which is causing the body to have that lateral flexion pattern. Now just think of it. We'll talk about this again more later, but lateral flexion, this way. Person's stuck like this. What it means is they're not getting stimulus from this side. When you laterally flex, you compress the facets throughout the spine. Compressing the facets is what fires the receptors in the facet joints. So if you compress the facets on the right, you're stimulating the facets on the right to go to the cerebellum on the right, cross to the midbrain on the left, into the cortex on the left. That person is stuck like this. They're getting maybe too much input from the facets on the right, certainly not enough from the facets on the left. And if they're stuck in a lateral flexor pattern, it's secondary to an endocrine problem, usually a thyroid or adrenal. It could be reproductive as well. They're stuck in a pattern that's creating all day long, 24 hours a day, imbalanced input into their brains. The imbalanced input into their brains is causing potential excess activity in one place and deafferentation in the other place, lack of stimulation in the other place. And people don't walk like this. Sometimes they do, but they don't often. They walk, but their body's like this, and they walk around, they lie in bed, they're stuck like that all day long, they get this imbalanced afferentation. And that can drive the brain to be off too. And so it can just cause a constant stimulation, either depolarization or lack of depolarization, overstimulation or understimulation of nerve pathways, all the way up. Cerebellum, midbrain, cortex on the other side. Not to mention what the cerebellum does by dumping into the autonomic centers in the brainstem as well. But you get these imbalances. So we check lateral flexion. If we find that pattern, we have to then address the endocrine system. If we haven't found it earlier, we find right brain, left brain activity can also affect the endocrine system, can be affected by the endocrine system. So the next thing is, what if there's a fixation? What if a person's got like a fixation, and maybe it's a long-standing fixation because they sit all day long and they do a job of putting something together on the one side of the body. I'm just making up an example. Or maybe they're a cook and they always using their right arm to stir pots or something. So they're kind of, or a dentist. Gosh, a dentist. That's a good example. Always a dentist usually on this side. So over a long period of time, they could get some spinal segments which get fixated. Now, in AK, Dr. Garrett found that there were bilateral muscle weaknesses associated with fixations, right? So we might find that there could be a fixation that would be related to bilateral muscle weakness. But sometimes these patients have been in that pattern for so long that they don't have the bilateral muscle weakness. And we wouldn't necessarily find the bilateral muscle weakness that you'd expect with the fixation. But you would find its location by doing a challenge, which we would challenge the semicircular canals. And if a patient was, had a fixation somewhere on the left side of their spine because they were a dentist and they were doing this all day long, and then they were on your treatment table. So there's something on the left posterior side that was fixated. And you found this pattern where they had a coprofactor alpha, maybe, or maybe glutamic acid, are both causing the right brain to Chapman's reflex. And you didn't find near far, jaw forward back. You didn't find lateral flexion this way or that way. But there was a structural lesion at one particular segment, or two segments as a fixation would be, and it's posterior. You can identify that by challenging the semicircular canals by simply having the patient put their head in a position where when they move it, it fires off a particular semicircular canal. So the patient could turn their head to the left, which would fire off the left lateral semicircular canal. They could put their head to the left and tilt it straight back, which would fire the left posterior semicircular canal. Or they could put their head to the right and then drop their head forward, which would fire the left anterior semicircular canal. But in the case of this fixation, what you find, that let's just say, it could be a couple different patterns, but let's just say they had this fixation on the left posterior side. You got this TL is positive, they turn their head, tilt their head back, and it negates the fixation. I mean, it negates the weakness, the challenge weakness. Turn head to the left, fire the left posterior canal, and now that negates this therapy localization, which is related to the brain imbalance. And what that means is they need something more to fire their left posterior canal. There's a problem on the left posterior side of their body, left posterior quadrant of their body. Because when they fire that canal, and they get a strengthening response, they're firing muscles, both intrinsic muscles of the spine and extrinsic muscles. They're firing those muscles, and those muscles then, which normally should be firing, if they're not firing because there's a fixation, for example, and there's not enough movement. But when you fire them by firing the canal, then if that corrects the therapy localization brain reflex on the other side, then you know you've got something on your left posterior side you've got to deal with. And if there's a fixation at, say, T12 and L1 or something, you will be able to identify that. In a way I'll show you, basically you rub over the different areas of the spine or different areas in that quadrant until you identify it. You find the area and then you challenge that area. And you challenge it for fixation regardless if there's a bilateral muscle weakness or not. And you correct it. And you start to restore afferentation, which then starts to fire that posterior canal of the cerebellum, which it wasn't firing before, which then fires the brain on the other side in a balanced way to bring back normal afferentation to the cortex on the other side, which was part of the mechanical part of the problem related to the chemical problems we already found. So I know I'm going to go this fast, but we're going to go over each part of it. I'm just going to give the overview because we're going to demonstrate these things. And we'll have a patient, as I said, coming in a little while. But to give you the overview, and we'll go through, pick apart each one of these things individually. It's actually pretty straightforward. It's not that complicated when we actually get it and pick it apart piece by piece. But just to give you the overview. And as I always say, first time I talk about it, if you don't get it, it's okay. But it means the second time I talk about it will be the second time you hear it. And then by repetition, it'll get better as we go through the weekend. Then if we don't find some problem in one of the body quadrants related to semicircular canals, then what we can do, well, we can check the immune system by therapy localizing the Chapman's reflex for the spleen or the thymus on the right or the spleen on the left. And sometimes if there's all else fails, there could be some kind of a TMJ issue. So the procedures in this seminar are based on the paper AK Assessment and Treatment of Inflammation in the Brain, the so-called Brain on Fire Syndrome, which I presented at the ICAK Canada meeting in September 2012 and the ICAK USA annual summer meeting in Los Angeles in June 2013. So this is again a repeat of what I've done before, but just to contextualize the whole thing. In the conclusion of that paper, we said manual muscle testing provides a real time. It's real time. You don't have to wait for the lab test to come back from 2 weeks from now. Not that that's a bad thing, but it's a real time assessment. And what do you do if you have the lab test and you paste the patient on the lab test and you can do another lab test before you treat them again? So it provides a real time somatic window on neurological and neurochemical function that allows the clinician to penetrate the uniqueness of each person's brain function. And imbalances in nutrition create or aggravate problems with neurotransmitters and inflammatory mediators. And each imbalance summates with other imbalances. They all add on and is aggravated by excess or deficient sensory activity from muscles and joints, viscera dysfunction, and cortical functions. So all these things add together. Cortical functions could be a patient's emotional state, for example. They all add together. And so manual muscle testing assesses for the most appropriate therapy or therapies for each patient on each office visit in a manner that's unparalleled in the healing arts. And we've said that before. So the 3 therapies then are, in the brain on fire, correct neurotransmitters by supplying precursors and cofactors for the neurotransmitters, correct sources of inflammatory cytokines by supplying antioxidants, and we also talked about last time looking for glycine, something we're not going to focus on at all today, but glycine can inhibit some excessive antibody formation and also helps the body to break down cytokines in the liver. And then restore optimal affermentation, which is appropriate neurologically based therapies, which we're going to focus on this weekend. So at this point, I'd like to say, does anyone have any questions or comments or maybe any interesting cases you had from what we talked about in sessions 1, 2, or 3? You might want to share any interesting findings or outcomes, or if you have some questions or comments that were unclear. Yes, Phil.
So there was this older woman who, when the night sweats came back, that I started counting backwards from 100. I kid you not. And she said, and they went away, and they haven't come back since.
So did y'all hear that? The patient had night sweats. They came back. She was angry. So she, after you fixed her with the nutrients and so on, but then she was angry, so she started counting backwards from 100, and her night sweats went away like that. So she was actually doing self-imposed neurological rehab on her left cortex. Yeah, that's pretty cool. Yeah. Anybody else have anything interesting like that to share? Yeah, Neil.
You mentioned working with it and just self-corrected it.
So what he was saying was, I'm really repeating this for you all to hear also in case it gets on the video, but he had some patients who, based on my talking about oxygen, and when we talk about transnodal degeneration, we'll repeat a little bit of that today in a little bit different context, but because based on the oxygen, trying to use oxygen, you found that some patients had certain weaknesses that would respond to oxygen, but when you turn the oxygen off, the way the weakness would come back. And then you'd find they also had some kind of a certain neurological pattern, some rich belly patterns of assessing a certain pathway or a certain part of the brain that was off, and you found out that if they did that therapy that you would normally do to stimulate that pathway along with the oxygen, then you get the oxygen to have its response to stay put. And the idea of that was the pathways you were finding in those cases were probably pathways which were overstimulated and were exhausting. The patient needed that pathway to be stimulated, but it was being overstimulated, and then the neurons were getting too close to firing threshold, and they were getting like whipping a tired horse, exhausted, and then supplying the oxygen allowed the horse to kind of be fed and pull the reins in on them a little bit. And so you're stimulating, you're not stopping the brain part from working, you're not stopping the horse from going forward, you're just slowing them down so it can operate at a more appropriate function. And so the oxygen, along with the other therapies combined, you find to be very valuable. And that is a useful thing to know about. And if you have a chance to have oxygen in your office, there are certain times when patients will respond to oxygen, and doing it sometimes in conjunction with other therapies is also very useful. Now, it's not really something we're talking about in this particular course as specifics, but sometimes you have a patient, I know you've all had patients who did this. You've treated them, you've done something to them, and all of a sudden they go, they'll yawn. Haven't you had that happen sometimes? Or they'll say, boy, I'm so relaxed, but they're really tired. They lie on the table and they're like relaxed, but maybe they're like a little over-relaxed. Well, now sometimes people are all uptight and need to relax them, but sometimes they just say, oh, I'm so relaxed now, I just don't even want to get up from the table. That's a little too relaxed. Sometimes what you've done is you've taken a part of the brain that was overstimulated and you stimulated it more, and you elicited a response, just like you could take a tired horse and whip that horse and make it go faster. But it's not to the benefit of the horse, it's to the detriment of the horse. And sometimes when you overstimulate a patient, and it's the right direction but too much stimulation, or the wrong kind of stimulation, you fatigue the parts of the brain. And at the place where Jeremy Rance and I go every year to consult at the Institutes for the Achievement of Human Potential in Philadelphia, where they treat brain injured kids from all over the world at the institutes, they say, and other people say, but they say that a yawn is the brain's cry for oxygen. And so what happens if you treat a patient all of a sudden a yawn, you probably overstimulated something a little bit. It's like whipping that tired horse, and now it's like fatiguing a little bit. Or if they feel like so relaxed. So it's not at all uncommon. If I see a patient yawn, the first thing I do is I whip up my oxygen and I have them breathe oxygen for 30 seconds or so. And it sort of then gives the oxygen to those tissues so they don't get over-fatigued. It lets them build back up. Same thing if a patient is really, really tired at the end. Or if I'm doing a Romberg test or something like that, or some kind of a neurological test and it's worse than when I started. Or if I do it and it's better, but I do it the second time, maybe they can stand for 5 seconds on one foot. And then I treat them and they can stand for like 7 seconds on one foot. I always give people a second chance to do it. I always give them 2 or 3 times. If they do it the second time, after I treat them, they're doing 7 seconds, and they're back to 5 seconds. And I give them a third time, they're back to 3 seconds. You see, it's fatiguing. So in that case, I'll have breathe oxygen, and they'll bounce right back up to 7 or 10 seconds or whatever. So you can fatigue people if they're yawning, or they're a little too relaxed after treatment. You may have overstimulated some areas that were fatigued, and you got a response from the patient by whipping the tired horse, but you may have left them in greater fatigue. So in those patients, if you have oxygen, have them breathe some oxygen. 30 seconds maybe. Just breathe it without doing anything if they're just lying on the table like that. Or if you don't have oxygen, have them do some deep breathing. Slow deep abdominal breathing to help to oxygenate their tissues a little bit more. So that's another way you can do it if you don't have oxygen available.
I kind of kept on turning the oxygen off, And if the problem would come back, I'm breathing some more until the problem cleared up, and it wouldn't come back. We have much greater pain, we needed much more.
Yeah, so the amount of oxygen people need is variable. I can almost look at him and tell. I have this one guy, his face gets bright red. After I treat him, he says, and he's been a patient of mine for over 20 years. He comes from out of town. I see him a couple times a year, 3 times a year maybe. And whenever that happens, when I've pushed him a little hard, he says, I need some of the good stuff. And that means he needs to breathe the oxygen. He knows how it feels now. He gets all bright red in the face. But so that's an interesting comment about TND. We will refer to that again later today. Any other comments or cases of, okay, yes, sir. So you had the patient with concussion, and then you found the weaknesses, and you found out which neurological stimuli negated it, and then that helped to bring out, some weakened them and some strengthened them. Sound weakened them, and olfaction strengthened them, and that helped to restore his function there. Yeah, concussions are, as we know, a lot more common than we used to think because of better awareness. But anybody gets hit in the head and has a headache, they got a concussion. I don't care if they pass the concussion test or not. If you get hit in the head or get banged in the head and you got a headache, you had a concussion. You get. Maybe if you're an athlete, you pass the concussion test, you go back in the game. But you got your cortex or cerebellum or somewhere in your brain dinged a little bit, and you'll find findings. And you can do this. That's a good creative way of identifying. It's sort of similar to some of the things we're going to talk about this weekend. Any other cases or comments? Yes, Carol. I'm going to sort of repeat as you go along because I don't think you can hear it. So she has a patient who's HIV positive.
He does a lot of work on his place.
He's got a resort. He does a lot of work on his resort. Physical work.
Yeah,
Mm-hmm.
he was so happy.
So after you'd fix the procedure.
So much energy, and I thought, how did I go wrong? Did I do too much? He was so excited, he hasn't felt like this in years.
So what she's saying is this guy has this resort and he works on it and paints it and does upkeep and so on. But after she did the brand and fire stuff that we've done so far, the guy came in the next time and he had been like painting and doing all this work on his place, and he was like had the most energy he had and was accomplishing things he hadn't accomplished. I'm sort of putting words in your mouth, but it was like he was very excited the fact he'd been able to do so much and had so much energy. So what kind of energy did you restore in him? Did you restore physical energy or mental energy? Did you restore physical energy or neurological energy?
15, like
Both. Yeah, because you found some chemistry that's going to affect his neuromuscular, I should say, affect his muscles, his mitochondria probably, and some of the things that are helping. But then you also stimulated the brain parts, which were fatigued probably or overstressed and going toward fatigue, and then they built those brain pathways up. So when people say they're tired, Sherry Rogers was a medical doctor in New York who wrote a book called Tired or Toxic. And the difference between those two things is a person could be toxic and have the same symptoms, is if they're tired, meaning they don't make enough ATP, so make enough adenosine triphosphate to produce energy. But the symptoms are the same. So you could be tired or toxic, but you could also have fatigued brain neurons and you couldn't tell the difference. Because when the brain fatigues, the neurons in the brain fatigue, you might think you're really tired because your brain doesn't want to work. And you might think your limbs are tired. They don't want to work because they're not getting the messages from your brain. You might think that your mind is fatigued and you can't concentrate. Well, it is, because your brain's fatigued. Your brain's neurons are fatigued and not firing properly. Their brain on fire. So all the different kinds of patients that have fatigue, there are those who are tired. They need more ATP. Who are toxic, they do have some toxicity, which is interfering with the energy production in the mitochondria or elsewhere in their brain. But then there's this whole group of people who are being missed for their fatigue, who what they have is they have inflammatory processes and maybe neurotransmitter imbalances, which is causing the brain on fire pathways to be fatigued, certain neural pathways to be fatigued. In addition to that, when there's inflammatory process and it crosses the blood-brain barrier, these inflammatory cytokines can affect the HPA axis, as we talked about last time, and turn off the HPA axis. So the person may have good enough adrenals, but the adrenals don't respond because the HPA axis is inhibited from the inflammation. So they feel tired physically, but the problem is actually in the brain from the inflammation in the brain. So a lot of people who have fatigue, we have to look at it totally differently than we looked at it before. Yeah, it could be low blood sugar. Yeah, it could be low adrenal from an adrenal problem. But it could also be neurological, possibly from an adrenal problem from the HPA axis being inhibited. Or also it could be a neurological problem because parts of the brain just don't want to work. They're fatigued. They're exhausting. And that part of the brain is on fire. So when we start to look at fatigue, when I hear a person say they're tired now, I have more options. Now I've learned about this in the last several years. Any other cases or thank you. Any other cases or comments or questions about anything from what we've done so far in the course? Okay, I'm gonna tell you one of my own, just to give a perspective. I had a patient come from a long distance. I saw just this week. And the patient had serious ataxia. I mean, big time ataxia. You're walking along all of a sudden, like that. Patient had been worked up by a top-notch medical university. They couldn't find anything. So what they came up with the conclusion that he probably has a genetic or hereditary genetic disorder causing ataxia and attacking his primary cerebellum. He had nystagmus, he had ataxia, he had a number of other things. He had some memory issues, but when you do the test, there's something called spinal cerebellar ataxia. There are about 40 different kinds of it, or 30 different kinds of it, SCA. It's a genetic thing. The test takes 6 months to find out if they're positive or not. Friedreich's ataxia, you can do tests for that. It takes a long time to get those tests back, these genetic things. Once they find the genetic marker, they still don't have anything to do for the patient. They can just say, now we got a diagnosis, tough luck. Well, I've only treated a couple of those genetic things in my life before. I treated one back when I was in Michigan 30-some years ago. I treated another one some other time. I haven't seen a lot of the genetic ones. I saw one last year, which I actually diagnosed as a genetic problem, but because I got it to a point, and after that certain point, I couldn't get any better. But what I was pleased to see, both with that one a year ago, that I was able to help at least to a degree, was even when there's a genetic disorder, you'd think the person's like stuck with that. Well, they are stuck with that. But you can still use these concepts, and you can still make changes. And you can make changes in the guy, and if there is a genetic process, you can at least slow it down, give him more function for the time that he's present and possibly slow down the process. It'll give more time before it totally ruins their life. And I was really pleased to see that this guy had really no bad food reactions, or he had a little bit of a food reaction, but it wasn't causing this problem. He had all the other brain on fire factors, nutritional, especially neurotransmitters. He had problems with 5-methyltetrahydrofolate. He also had a problem where he needed riboflavin 5-phosphate, which is the activated form of riboflavin, not riboflavin, but riboflavin 5-phosphate, activated form B2. So he had these other issues, neurotransmitter issues, and a couple. One in particular needed something to support his Treg cells. And then I treated him with the kind of things that we're going to talk about this weekend, as well as the nutrition. And we got really significant improvement in the guy, where he could walk and you wouldn't be able to tell the difference across the room. And it didn't cure him, but it really changed his abilities. I got him to be able to do a round with his eyes closed for 10 seconds, which before he could barely stand on one foot when we started. So even if there's a genetic compromise, even if there's something that everyone says, well, tough, there's nothing else we can do, still consider trying to see as much as you can get out of that patient as possible by using these techniques and these procedures, or anything else for that matter. Because there's no one who has the tools to look at neurological function like we have, especially with AK. And so the difference between black and white, all that gray area is something we can address and to treat. Other people say, well, it's either black or white. Oh, you got spinocerebellar ataxia or whatever it might be. Tough, sorry. Here, let's get you on some rehab, physical therapy, kind of keep you strong, do this, that, the other thing, and make sure you get a hospital bed and a wheelchair ordered, and because you're going to demise. Well, that's probably true, but if you can slow that process down and give him much better function while he's going through it, and maybe, who knows, I don't know if you can stop it or not, but if you can slow it down, don't be afraid to go for it, even if someone's told him there's no hope for him. Because maybe there is no hope for him, but then maybe there is, like this guy. Maybe there is. You just never know. So I want to share that with you just to say, you never know how much you can get out of a body. You never know how much you can get out of a nervous system. And if you don't try, and most people when they see these more serious neurological things, they don't try, or the tools they have are so ineffective because they're shotgun trial, one size fits all. You're there to be able to step in and make changes in patients which can alter their lives. And maybe you can save their lives, but if you can't save it, maybe you can make it worth living for the time that they have. And that goes for all types of diseases and disorders, but especially the nervous system. We can make changes which significantly alter people's nervous systems when other people think that's impossible. They just don't have the tools. Their focus is too broad. We can narrow the focus and find specific little things that we can find, as opposed to saying, well, it's either black and white. We can look at all those gray areas. So I wanted to share that with you because I was kind of really pleased that this guy, with all of his problems that he had in his early 40s, was able to respond as well as he did. It's not perfect, but we were able to make up changes when everyone else would say there's nothing that can be done. We all know that can happen, but that can happen with the brain as well. So in the following slides, note that any of the issues addressed, any things we're talking about in the next few slides, can arise totally or in part from altered neurological afferent activity in the central nervous system. These neurological factors are not addressed in non-manipulative approaches. This is kind of what I was just talking about. This represents a deficiency in other approaches and limits the potential for creating a positive response, to the point that we can't do anything for you. What is the brain on fire? It's excess neuron firing and/or inflammation leading to neuron misfiring, neurological signs and symptoms, and neuron cell death. What neurological symptoms are associated with brain on fire? Neurological disease named and unnamed, emotional symptoms, cognitive symptoms, autonomic symptoms, neuroendocrine symptoms, pain, etc. These are all the problems we talked about and more that can be affected. But there is a structural neurological component that we have as those of us who do any manipulative therapies that no one else is going to address that have significant and sometimes profound effects on patients. And that's the piece that I want you to recognize, is that what we're talking about this weekend is the part that no one else will do. No one else will do. So we start with the supraspinatus, the side of the problem. Could be any brain symptom, any chronic symptom. We must correct the switching first and then correct the right brain, left brain procedures from brain on fire 2, and this will correct some of the brain findings right there. But then when to look for the brain on fire? Well, any brain symptom. Brain injury, that includes cerebrovascular accident or a traumatic brain injury, concussion. Depression, usually you find it on the right. If there's a depression, you more often find the brain problem on the right, or bipolar disorder, usually find it on the right. Any chronic symptoms such as pain, weakness, neurological, or even AK muscle imbalances that recur. Autonomic, including recurrent ileocecal valves or recurrent Houston valves, or any recurrent gut problem, or any recurrent autonomic problem anywhere. Endocrine, neuroendocrine issues, and always you must correct the switching first. So when we normalize mechanoreceptor activity, and when we balance neurotransmitters and decrease the sources of inflammation, remove the sources of much structural, chemical, and mental distress, and restore systems that will increase both productivity and longevity. And so I just want to emphasize that the things we're talking about this weekend are the most unique parts, because no one else does that. The other parts with the chemistry we can do it more precisely, but the parts with the manipulation and the adjusting or the set point or whatever are unique to our abilities. Let's talk about the cerebral cortex descending effects. We know that the right brain, people say the right brain affects the left side of the body. Well, it does, but the right brain also affects the right side of the body. Right cortical activity descends and affects the right side of the body, and the left side of the body, but only 10% of the fibers really, 10% of cortical output goes contralaterally, 10%. And this is for purposeful motor activity. This would be like your cortical spinal tract and supporting tracts. 10% of descending cortical spinal fibers descend. Now, some of them stop in the red nucleus, and some stop in the reticular formation on the other side and descend, but only 10% of the fibers from one cortex affect the opposite side of the body. 90% of the descending cortical fibers affect the same side of the body, and they do so by creating changes in muscle tone and in autonomic function. So 90% of the fibers descend, and they'll create changes in muscle tone or autonomic function. And they do this through brainstem activity. So in muscle tone, cortical descending effects ipsilateral it decreases muscle tone in general on that side. It increases extensor muscle tone above T6, flexor tone below T6. And then it fires off the pontomedullary reticular formation, which is a fancy way of saying the lower pons and the upper medulla, which is where the vagus nerve is, dorsal motor nucleus is. It's where the vital centers are. And that then is the major parasympathetic area in the body. And the parasympathetics then descend and inhibit the intermediate lateral cell column, or the sympathetics here. So we look at the muscle tone factors first, and then we look at the autonomic factors also that can come from cortical activity. And we see that we get both muscle tone changes on the same side as well as autonomic changes on the same side of the brain activity, much more than the opposite side. We only get 10% of the muscle activity to the opposite side. So what this does, though, this allows us for this pattern we call figure of 8. So when the right cortex increases its function, it increases muscle tone on the right. Well, this increased muscle tone is perceived by the cerebellum. The cerebellum, by pathways that go to the opposite cortex, stimulate the left cortex. When you stimulate the left cortex, this causes increased muscle tone on the left side. Increasing muscle tone on the left side will, through the cerebellum, cross over and then stimulate the right cortex, which then stimulates the increased muscle tone on the right side, and you get this nice figure of 8. It's called a wind-up pattern. And as things are healthy, the body keeps itself healthy neurologically. One side of the brain stimulates the tone on that side, which then stimulates the opposite side of the brain, which stimulates the tone on that side, which stimulates the first side of the brain. And it's a nice, healthy way we're put together. So increased right cortex is figure of 8 pattern, increased right muscle tone, increased right cerebellum, fires off to the left cortex, then left muscle tone is increased because of the left cortex, then left cerebellum is increased, which then fires off to the right cortex, and round we go. We get this nice figure of 8 activity, keeps things healthy. By the same token, if there's a breakdown somewhere in there, a patient has an injury or a subluxation or a chemical imbalance, and organs misfiring on one side, then you get a breakdown of this figure of 8, and you can actually get, instead of winding things up, you can get what's called wind down reactions, and it can perpetuate issues in the central nervous system. So if you had a liver problem because your cholesterol was too high, your Chapman's reflex for the liver is here, it would be compromised, and you would not have normal rib movement on that side compared to the other side, and you would get an imbalance, and it causes a little bit of a wind down reaction, or not a full wind up reaction from these patterns from that one lesion coming from even a chemical imbalance. And this is something that we can recognize that no one else looks at either, is how these organ dysfunctions, especially the pancreas for blood sugar handling problems on one side, and the liver for cholesterol and other toxic problems on the other side, have unilateral effects on affecting brain function and helping to interfere with a full manifestation of this figure of 8 pattern. So what can we do to assess the cortex and the cerebellum in the office? Well, we can do gait assessment with right and left brain activity. The dual tasking, which we've done before. We'll do that again. We had the patient do 7 numbers to check their memory. We can do it atonal, 1, 2, 3, 4, 5, 6, 7, or total, 1, 2, 3, 4, 5, 6, 7. Give them 7 numbers and see if they can repeat them back, and checks for short-term memory. We do a Romberg test for balance, which is really a cerebellum test, but also a cortical test as well. We can do the finger-to-finger test, like that. We can do Weber's test, tuning fork on top of the head, which we did last session, and blind spot testing, which we've talked about, but not something that we've actually taught in this class. But it's another way of assessing right brain, left brain activity in the office from a diagnostic point of view using tests as opposed to muscle tests. So sources of abnormal cerebellum function tests are from either cerebellar disease or damage, like that patient I told you about that I saw earlier this week, or you could have pathology of pathways leading to the cerebellum, some pathology somewhere in the afferent pathways. But the most common thing we see is functional deafferentation. That is some lack of motion somewhere, a muscle or a joint where we don't get normal stimulation of the cerebellum. You can't tell the difference from the patient's symptoms, whether they have disease or damage in the cerebellum, pathology of the pathways leading to the cerebellum, or just deafferentation. The symptoms can be the same. So you could take a person who was staggering. They could have cerebellar disease. You have a patient who was staggering with ataxia. They could be drunk, not have cerebellar disease, just compromise it from the alcohol. Or you could have a person who had enough deafferentation where they weren't getting enough feedback and they were staggering because they were just, tend to like walk into things because they had subluxations and muscle imbalances that tend to just cause their cerebellum to shift more on one side than the other. All these things are possible. The most common thing we see in typical practice is functional deafferentation, but all these things can be measured by cerebellar tests. So the functional deafferentation can arise from any muscle imbalances secondary to nutritional imbalances as well. So we could have nutritional imbalances that will cause muscle imbalances that will throw off the cerebellum and give cerebellar findings, which is another concept that is kind of foreign to most people. So I want to talk about this one test, the amplified finger test. We do talk about this in the QA course, but I wanted to actually do it here and have you all do it to each other. And this is a test where you take the standard neurological test, finger, and you do it with the head in different positions. Now, most often the patient's lying on the table. So when they're lying on the table, close your eyes, touch your fingers together in front of them. Then what you would do in the amplified finger-to-finger test is you would rotate the head to one side. When you rotate the head, yes, you're changing net proprioception, but you're also changing the feedback from the inner ear. And you're putting the head in a position which changes vestibular feedback. And so have the patient turn their head and touch their fingers together, and they're lying down now. Tilt their head the other way and touch their fingers together. If you had the patient sitting, it would be best to have them sit, touch their fingers together, laterally flex their head to invoke that cerebellar function, the vestibular function I should say, and laterally flex the other way to invoke the vestibular function. But most of the time I do this lying down. So this is a test you can use. It will find, if the patient can't do it in one direction or another, you could have cerebellar disease. You could have a problem with inputs to the cerebellum from mechanoreceptors or from the inner ear or from the cortex. Mechanoreceptors could be any muscle or joint imbalance. And we can test then with the head centered, the right ear down and the left ear down. And so the 3 basic patterns, the normal pattern where the patient touches their fingertips together the same every place every time, off-centering dysfunction where they turn it one way and they miss one way and they turn it the other way and they miss the other way. Or it could be where they have a unilateral dysfunction which it's off, no matter where they put their head, it's always off in the same direction. So here's the head center. This is what would be normal. Head center, head right, head left, head center. Now abnormally, if there's an abnormality, you might find something like this. Head center, head right, head left. And that's what you do. You just put the fingers together like that. And so let's do that. I want to do that. I want you all to do it. You can do it sitting or you can lie down. and do the amplified finger-to-finger test, where you do the test with the patient turning their head to the side and do it, and the other side and do it. I give people at least 3 times to do this before I make a decision on how well they do it. It's not something people do every day. So give them a chance to practice a little bit. So let's take a couple minutes and do the amplified finger-to-finger test and note your responses, note your findings. Now, the Romberg test is where your patient puts their feet together and closes their eyes, and you watch for the first movement, direction of first movement. Not the biggest movement, but if they move to the right, then you write down right. The person puts their feet together, closes their eyes, they go right, and then they go like that. It's still the first movement you're looking for. So the direction of movement, of first movement, will guide you to see if there is a particular direction. That will be the side of the cerebellum that needs some attention, or opposite from the side of cortex, which needs attention. So that's the Romberg test, feet together, eyes closed. Observe the first movement, and then observe for overall stability. Make a note of the responses. Then we're going to do 1 foot Romberg. Stand on 1 foot, eyes open. Note the times it takes for 1 foot standing, and you should be able to do 20 seconds. A lot of times I'll quit at 10 because they're clearly very stable. But 20 seconds is optimal. That's 1 foot standing with eyes open. Then check for the 1 foot Romberg with the eyes closed. Have the person get steady with their eyes open, then close their eyes, and see how long they can stand. And note the steadiness and the length of time. I give people 2 or 3 times to try this, again, before I make a final decision. And have them do it on each foot, and this is more of a cerebellar test for the side they're standing on, although it could be partly cortical on the opposite side, but you could actually note the findings on this, and we'll use these later. So let's take a couple minutes and do this little workshop, make notes of them, and then we'll use them later to monitor after we change some things when we do some treatments. And yes, Jeb?
When we're doing Rombergs, we want to do it with our shoes
Ah,
off.
well, when you do a Romberg, you do it with the same, if your shoes are off or shoes are on. I don't care how you do it right now, but in the office, you just make sure you do it the same before and after. So if you got your shoes off, leave them off. You got your shoes on, leave them on. You can do whatever you want, but always do it the same because it certainly changes things. It's a good point. I usually do it barefoot. Unless the person, for some reason, just has such bad feet they can't be barefoot. You know, some people that have distorted feet and they really have to wear shoes all the time. I see this I saw this in some older women in years past, and we're going to see it in the future, who wear high heels so much their feet are distorted and they have to wear shoes. They can't stand on bare feet. With all the high heels around now, we might see that again down the road a little bit. Okay, so just either way, but as long as you're consistent from time to time. Let's take a few minutes and check the Romberg, and after we finish doing that, just work into a break. Was there a question before we start?
Ipsilateral cerebellum, contralateral cortex.
Usually ipsilateral cerebellum, contralateral cortex. Now the 1 foot, you could have an ipsilateral cortex because of the ascending muscle tone too. It could be complicated, but yeah. But typically ipsilateral cortex, ipsilateral cerebellum, contralateral cortex. So do this workshop, make notes of it, and let's take about a 10-minute break after that. We'll check on the Duke scores. I've got a code for this room for the internet. It's I think it's all capitals. PNCDI7. P is in Paul, N, C, D is in dog, I7. So fully that can get you on if you're not on. Okay, let's continue. So what I want to do is I want to now take someone and demonstrate just the things we're talking about this weekend, sort of an overview. And then we'll get on to it a little bit more, but I want to just sort of demonstrate the concepts of what I've been talking about. And so we have sort of a visual of it. And then a little while after the next break, about an hour and 15 minutes or hour and 20 minutes, we'll actually have a patient come in and we'll go through a full procedure of all sessions, whatever she needs. But right now I'd like to have someone volunteer who maybe has some symptoms of some of the things we talked about, or maybe who had positive findings before when we did the workshop. Anybody want to volunteer? Okay, come on. Stand right here for me, please. Now, face me. So what I'm going to do is I'm going to see if I can find a supraspinatus which goes over when I rub one of the Chapman's reflexes. Push out hard. And first I'll test in the clear, and it's normal. I'm going to rub the left brain reflex that Chapman talked about, and it still weakens when I do autogenic inhibition. I'm going to rub what I call the left cortex reflex and do autogenic inhibition, and that weakens as well. That's what it's supposed to do. So we'll try the right supraspinatus, and it weakens on autogenic inhibition. Make sure it's strong in the clear. Okay, it is, again. Yeah, and then we'll rub the right Chapman's reflex for the brain and see if it changes, and it does inhibit like it's supposed to. Now we'll do the right cortex Chapman's reflex and test again. And we rub the cortex, which is on top of the clavicle, the cortex reflex for the right cortex, and then do muscle spindle selectivity. It doesn't weaken the right supraspinatus. This means we've got a right cortex issue that we're going to try to evaluate. So come on over here for me now, please. We switch seats. You sit down. You sit over here, please. Yes. And put your fingers right where I was rubbing. This is right on top of the distal clavicle. And we're going to test the latissimus dorsi here. You know what I'm going to do? I'm going to stand up for me, please. What I'm going to do is I'm going to move this down here so I can approach you from this side. So sit right here, please. Touch right here, and we'll test the strong indicator muscle, latissimus dorsi, and it's strong. So now we're going to challenge with some cytokines. Now what I usually do in my office, I usually have the 1 ounce dropper bottles of TH1 and TH2, and I'll start with those, and then I'll go to individual ones, but I don't have those right here right now. So I'm going to start challenging with some inflammatory cytokines, and I'm going to start with tumor necrosis factor alpha. Put your fingers right there. I'm going to go until I find one. I'll use the magnet testing. Pull hard. And I get lucky, and TNF alpha, which is a common one, will weaken when she touches that brain reflex. So I've got a pattern where I've got a weakening cytokine, and I can also check for a neurotransmitter. But the I think I'm just going to use the cytokine to demonstrate this procedure, because the procedures of the structural findings that I want to demonstrate. So what you'll find here is in your notes, let me see, I think I might have the slide for this. In your notes, you have two procedure summaries. One is called abbreviated procedure summary for putting out the brain on fire sessions 1 through 4. This is kind of the overview of everything we've done in all 4 sessions, which we'll use when I treat the patient a little while from now. The other one is procedure summary for putting out the brain on fire session 4, and it's 1 page like this, and it's got some highlighted things to focus on the things we're doing this weekend. So we're going to try to find some afferent factor that negates the weakness, but before we do that, we're going to do, we're at that page, we're on number 2, and we identified, actually number 3, we identified a cytokine that negates weakness. I'm not going to try to identify the cytokine that negates, I found the cytokine that makes the weakness. I'm not going to do the B and C, the A and B part. I'm going to go to C, and we'll check the sympathetic factors, near fire vision and protrude jaw, and see if there's one of those. Put your fingers right here. So, hold here, resist. Focus your eyes on a distant object, challenging for sympathetic activity. Look at the tip of your nose, pull. Challenging for parasympathetic activity. Neither of those negates the weakness. Stick your jaw forward, parasympathetic. Pull your jaw back, sympathetic. And none of those are changing the weakness, so I'm not going to look for visceral pain areas or anything like that. Okay, touch right here again. Right, actually, just move to your chromium. Okay. I'll check lateral flexion. Tilt your head and body that way. And now we're compressing facets on the left side, and that should drive the left cerebellum to the right brain. And that doesn't negate the weakness, and I'll just do it this way, although usually we'd find it in the other direction for checking the right brain. But it could be either way. Okay, and that doesn't negate the weakness. So that's lateral flexion challenge to see what negates the weakness. Now I'm going to check your semicircular canals. Now, there are very precise ways you can do this. You don't have to be, you have to be accurate, but you don't have to be super precise when you do this. So let me just change this here. Okay. So I've got the cytokine, I've got the magnet. I'm going to check, because I'm looking at her right brain, the input to the right brain is going to come sensory from the left side of the body. Everything on the left side of the body sensory goes to the right brain except for olfaction. Olfaction stays on the same side of the brain. Everything else crosses to the other side. So what I'm going to do is I'm going to check her left lateral canal by turning her head, her semicircular canal, turning her head laterally that way and seeing if that negates the weakness. And it doesn't. With her head turned that way, let's come back slightly, trying to line up the posterior canal, I'm going to challenge the left posterior canal, which fires the left posterior canal, and that negates the weakness. That means there's something, I don't know what, on the left posterior side of her body that's deficient, and when we activate that pathway, it strengthens the muscle, so we have to treat something that side so she doesn't have to walk around tilting her head back like that all the time. Okay. Now we can check the anterior canal by turning it this way, the left anterior canal, and taking the head forward, pull hard, and there's not a left anterior canal problem. You have to do this pretty quick. You have to test pretty quick after moving the head, because the canal only fires briefly. The pathways for the canal fire. The canal, I talk about the canals. There's a slide that says I think the left canal, the right canal path. It's really the pathways that are firing from those canals that are compromised. The semicircular canal might be compromised, but in these kind of patients we're talking about this really the pathway related to the canal. But I talk about left posterior canal not working right. It's not necessarily the left posterior canal. It's not working right. It's somewhere in that pathway that's not working right. So the other thing I could do then is I could have her therapy localize to her spleen reflex and lift your knee up here, push, and then challenge with the spleen or with the thymus, touch right up here for the thymus reflex, and see if the spleen or the thymus negate the weakness, and they don't, just the left posterior canal. Now, I have to find something on the left posterior side of the body that negates this. This is really pretty simple. It's kind of crude, but it's pretty simple. I'm just going to rub my hand up and down the back side of her body. I'll usually start at the cervical spine. It could be in the head, but usually start at the cervical spine and rub down and just do a simple stimulation of rubbing. We'll do the thoracic spine. And somewhere in there where I rub the thoracic spine negated the weakness. I'll go down the lumbar spine and sacroiliac, and it doesn't negate the weakness. But if I find the thoracic area, I'll find one area, I'll rub that area, like I'm rubbing like right now, T12, pull hard, T11, T12, now I'll go up to about T8, T9, pull, T7, T8, I'm rubbing on the left side, T5, T6, there it is, let me see exactly where it is, it's T5, pull hard, and there's something at T5 that negates that weakness. Now I haven't done all the preliminary procedures, I haven't unswitched, I haven't done any of that, but I've got something at T5. So, take your hand away, please. Now what I need to do is I need to identify what it is. Hold your arm here. So, I could pinch over that area. Here's the flex reflex afferent challenge to see if there's a subluxation. Pull hard. Doesn't appear to be a subluxation. I could now take a strong muscle and rub over that area. And when you do a strong muscle and rub over an area, I'm looking for maybe set point technique. I'm assuming she doesn't have an injury. It should have been all cleared by now, but set point technique. When you check for set point technique, you have to use patient-started testing. Pull your arm in, like a G2 type test or patient-started testing where they get a little bit of a head start. So pull your arm in and now resist. Okay, now bring your arm in, pull it into your side, now resist as I pull out. So the patient gets a little head start. We talk about these different types of muscle testing, different variations of muscle testing in the first and second sessions. Pull in again. And when she gets a running start and it locks, that's normal. Now, if there's a set point, and I rub there, pull in again, it'll weaken. And it does. So she's got probably a need for a set point technique there. So we have a set point, probably a set point. It could be a subluxation too, but it's probably not a subluxation because I pinched there. It could be a fixation too, but it may just be something as simple as a set point. But if I challenge for set point and don't find it, then I will challenge it to see if it's maybe a subluxation or a fixation at that area. So, can you reach this hand all the way back over to here? About T5. Yeah, that's pretty good. Can you look closer to the spine? Might be easier, okay. So now I'm going to check for set point technique. Hold, touch and tap technique. I'll check bladder 1 first. I'll check T5, I'll check gallbladder 1. There's gallbladder 1. So it's actually a set point for T5, T4, T5, gallbladder area. So what I'm going to do then, take your hand away please, is I'm going to measure something before and after I do that set point technique. Do you have something, how was your 1 foot stand? Did you do it?
Yeah. It wasn't so good. The dial was terrible in the 2 seconds.
Okay, and how was your finger to finger?
It also wasn't so good.
That's good. Let's do the 1 foot stand. So stand on 1 foot, and when you get steady, close your eyes. Okay, do it again, same thing. Okay, do the other foot. Okay, and one more time on the left foot. I always give them at least twice, unless they do it so well the first time. So you're getting 3 or 4 seconds at best. Okay, sit here again, please. And reach around and touch that T5 area again. Okay, now, again, this is gallbladder while she touches T5, resist. This is a regular muscle test, resist as I pull. So I'm going to just do set point technique. I'm going to tap here about 100 times. And 100 times at the rate I'm tapping, which is about 4 or 5 times a second, will take about 20 to 25 seconds.
The patient can't reach.
Patient can't reach, good question. And in this area of the spine they can't reach, I usually tap it or rub it myself. I just do something to stimulate it so the brain's getting the message of proprioception, even though it's better when they touch it. It'll work. I usually tap a little longer when I do that. That's got to be 20 to 25 seconds. Okay, keep your hand there. Hold your arm in again. We'll tap again to make sure that it's better. And it still shows a need for some more, so we'll tap some more. Now, granted, we haven't done all the other things to her, so I don't know what's going to happen, but usually it should have fixed by now. I suspect there's, we skipped over something that would have made this correct faster, whether it be an injury somewhere or a right brain, left brain issue, but. Okay, I'll hold here again, resist. Now tap again, resist. It strengthens now. Okay, now switch hands and put your fingers right up here on top. And then let's test with the cytokine, the TNF-alpha, that caused that brain reflex to weaken. Again, pull hard. And it actually still weakens. Okay, so we got to go back to the drawing board. And we could test the nutrients and so on for it. We probably should do that touch right here again. Let's just see now if she's got something else that maybe she's more than one thing and shows up maybe one at a time. Turn your head this way and tilt your head back again. Pull your arm in hard. And there's still something on that left posterior canal. So keep your head straight. I'm going to rub down the spine again. Pull hard. Pull again. It's really just about in the same area. That negates the weakness. Pull hard. Pull. It could be a whole bunch of things that would be associated with, we haven't checked yet, but I'm trying to just, yeah, it could be a lot of things. But yeah, it's a good point. And it still shows T5, so I'm going to ask you to lie face down for me, please. So it may be that the set point was there because there's an underlying subluxation, or maybe a fixation, and that's what you find a lot of times. So what I'm going to do, I'm going to challenge, and I'm not going to necessarily check for the bilateral muscle weakness. I'm just going to challenge T5 on T6 and T5 on T4, and hold your arm in here. Actually, hold your arm in here so people can see. Push in. Challenge T5 on the left, T6 on the right, T5 on the left, T4 on the right, T5 on the right, T6 on the left. There it is. T5 on the right, T6 on the left, and there's a fixation there. T5 on the right, T4 on the left. It's between T5 on the right and T6 on the left. Now, this would be a thoracic subluxation. You would think that in typical AK terms, there would be a bilateral what? Teres major. Put your fist in the small of your back, please. There may or may not be. The point is, oftentimes there's not. Push against me hard, please. And she doesn't have that. Now, sometimes you could add weight bearing, as if you were upright, push. But these type of fixations sometimes have been there for a long time, and they're sort of locked in. I started to talk about this a little earlier and kind of got off track on it a little bit. You can get a fixation which doesn't show the bilateral muscle weakness because the body's so used to having it be there. And it may actually require manipulation to stretch the ligaments and break, mechanical fixation has been there for a long time, like the chiropractic subluxation syndrome kind of subluxation, or fixation. So, hold here again, resist. When I find one like this, I usually do first a respiratory correction, then I adjust it. So I'm going to ask you to take a breath in and push your arm in here. When she breathes in, it negates the weakness. So I'm going to correct this on respiration, then I'm going to actually manipulate it. I have this thought in my mind, and you can palpate for motion palpation and see there's differences. But I have the idea that sometimes this really requires not just a correction of a subluxation, but really actually stretching of some of the ligaments that have been there for a long time. So, do this again here. Get the right spot. Pull hard. Yeah, that's it. Take a breath in and let it out. Breathe in and let it out. Breathe in and let it out. So I'm kind of pushing apart, P to A, but also kind of pushing laterally on both sides. Breathe in, let it out. Breathe in. And now I'm going to adjust it. That's okay. Okay. Pull hard. Now, every time I find a fixation, in the thoracic, I always check to see if there's an anteriority underneath it. A lot of times the fixation is there to protect against the anteriority. So I'm just going to push P to A to challenge it. And it doesn't show that. But I just find it a lot, so I just routinely do that. Okay, sit up for me again, please. Let's go over this way a little bit. Put your fingers right here again. Pull your arm in, pull hard. And now we negated the challenge weakness with the cytokine. I don't know if that's going to change anything or not, but stand up again for me, please. Let's just see if it changes anything with the 1 foot test. And stand on your right foot, and then when you get steady, close your eyes. Okay, do it again. Yeah, this is better. And the question is, could the boots be affecting it? Yeah, but if you have the shoes on or shoes off, boots on, boots off, whatever you do before and after, just do it the same each time. So it could be having an impact on it, but I'm looking for change, really. Stand on your left foot for me, please. You steady, close your eyes. And one more time on the left, please. So a significant improvement from fixing that. It wasn't from fixing that fixation as much as it was for fixing the brain that was triggering off that fixation. It's triggering off a whole imbalance on your right brain. Now, that's just a demonstration, and it's out of context, but it was a pretty good response. Thank you very much. And you wouldn't think to get a response like that from fixing a T5, T6 fixation that you get such a dramatic response on, and you wouldn't normally get from just doing that, a dramatic response on something like a neurological test for the cerebellum. But if you find the one that's the culprit, that's really the main one that's affecting the neurological pathway, in this case her left cortex, her right cortex, coming from the left side, then when you find it, you're more likely to see big time response. So it was a pretty good demonstration of going through the procedures, and then also she actually responded to that. And we didn't do all the switching, unswitching and stuff first, and that may be something that's important, and this may all wind down again because there may be other things we didn't fix, but that's the kind of how we go through it when we find the challenge mechanism, we go through those structural things. All right?
When she was face down, you were challenge her for fixation, right? You didn't challenge her subluxation because it's already become a positive.
Yes. He says, when I had her face down, I challenged for fixation. I didn't challenge for subluxation because, and the reason I didn't is because the FRI, when I just pinched her, it didn't come up positive. And it also challenged, when I challenged it, it challenged only on 5 and 6. It didn't challenge on 5 and 4. If it was just a subluxation of T5, it would have challenged whether I did it with 5 or whether I did 5 and 4 and 5 and 6. I just went ahead and challenged for fixation because it didn't show the FRA's pinching response to weaken. So if it was a subluxation, it would have made a difference if I challenged with T5 on the right. If T5 was subluxated on the right, for example, it wouldn't have made a difference if I challenged T5 with T6 or T5 with T4 or T5 by itself. So it was actually a fixation required both to make it show up, and only showing one of those. Okay? So T5 with T6. That's a good point. So once again, we have a little bit of a checklist here that can kind of take a step-by-step through what the structural issues are that might be related to the patient's neurological problems. So let's go on. Now, some doctors have viewed AK in the context of chiropractic neurology. A lot of AK doctors are taking chiropractic neurology, but in the Brain on Fire seminar series and in QA, we view chiropractic neurology in the larger context of AK. I'm a chiropractic neurologist. I love chiropractic neurology. AK gives me tools that allow me to be more specific and identify more factors associated with the neurological pathways than the more mechanical neurological approach only. Not that there's not value, there's a lot of value to that, but we can find out specific nutritional factors is probably the most important thing we can find with AK. And we also find the specific area of neurological stimulation. And we're looking for either excitation or inhibition with neurological stimulation the patient needs, what pathways they come from. We can find out what pathways we put in the patient through those different ranges of motion, lateral flexion, head, semicircular canals. We do autonomic challenges, eyes and jaw. We can find out which kind of neurological stimulation the patient needs, excitation or inhibition, which is the pathways, is it sympathetic or parasympathetic, is it structural, is it maybe even set point? And she had set point and structure. So we can identify what the treatment procedure is. And then we get the supraspinatus could be one of two ways. The supraspinatus could be weak in the clear, which we didn't see, or it could be overfiring. Now, it could be overfiring in the clear, but when we find a supraspinatus either weak or over, say in quotes, we're going to test the indicator muscle with therapy localization to the brain Chapman's reflexes, whichever one shows up with cytokines and neurotransmitters. And then we're going to find the neurological stimulation to negate the challenge weakness. So the supraspinatus weakness could be weak in the clear. We have to consider ruling all these possibilities out. Weak in the clear, sometimes it is. Weak on like a 51% with therapy localization to the Chapman's reflex. Usually not the case if you have first corrected the switching factors and the other things we talked about. Weak after ipsilateral olfaction. Remember, olfaction is only sensory activity that primarily is on the same side. So if you breathe in the right nostril, you'll be stimulating the right, basically limbic system, something that's called emotional brain. And the limbic system on the right is stimulated by the right olfaction, the limbic system on the left is stimulated by left olfaction. Everything else crosses. But you can have a patient who's got maybe limbic system issue, they might be depressed, or might be anxious, or might have some other emotional issue, and it won't show up, the supraspinatus will show up with olfaction. It will actually weaken if you have olfaction to overload that emotional brain. If it's like fatigued and they sniff in the nostril, you'll be stimulating the emotional brain, and it's like sometimes referred to as the mesolimbic system because the midbrain and mesencephalon drives straight up into the limbic system. And so you can challenge that with the olfaction. And then you can also take light and do light from the midline. And light from the midline will stimulate the midbrain and mesencephalon on the side to which you're pointing. And that can sometimes weaken a patient if the supraspinatus is weak in the clear, if the mesencephalon is fatigued. So if the mesencephalon is fatigued, or if the mesolimbic system is fatigued, or the limbic system is fatigued, ipsilateral olfaction can cause a strong supraspinatus to become weak on the same side with light from the midline. So light from the left to the right would stimulate the right midbrain or right mesencephalon, and that could also cause the weakness of the supraspinatus if those areas were fatigued and you add a little bit more. You kind of whip that tired horse and it's kind of exhausted. So you can have a weakness. Typically, I just check in the clear, and then I check it like in the clear, and then I go to checking for overfiring. And if I don't find overfiring, I'll go back and check the rest of these. Now, it could be over. Supraspinatus is over or biased toward facilitation is a better term for it. In other words, it won't weaken. Either it won't weaken in the clear, or 1 weekend after stimulating one of the brain Chapman's reflexes, the one over the coracoid process, the traditional one for the brain, or the one on top of the clavicle, which is for seemingly the rest of the cortex, a little higher activity. Or we can see it sometimes in certain mesolimbic or limbic problems. You can have the patient sniff in the nostril, in this case the right nostril, and test to see that the right supraspinatus wouldn't turn off. In this case, you're driving it farther into activity, and it's overactive already, and you're driving it farther into activity, and it doesn't weaken. Or with light from the midline, you could be challenging the mesocephalon from light from the midline. So if you put light from the midline and check the supraspinatus and didn't weaken, you could also check to see that did it weaken when you did autogenic inhibition. So these are all basically the same kind of challenges. One's looking for weakness where you actually already have a fatigue in the pathway, and one's looking for an area that's like whipping a tired horse is going too fast, and it's heading towards that, but it's not there now. So you get the overfiring of the supraspinatus, and it won't turn off with muscle spindle cell activity. So you have two options. Usually what I do is I have the patient test it in the clear, do muscle spindle cell. If it weakens, then I'll rub the Chapman's reflex and test again with muscle spindle cell. I'll rub the other Chapman's reflex and test again with muscle spindle cell. I'll usually find it that way. The patient has obvious emotional symptoms. Maybe they're depressed, for example, and it's obviously an issue. Or maybe they have cognitive symptoms. They're having trouble with their memory. They have some kind of a problem. And you don't find any of these, then you go back and check the rest of the list. Because it could be just with olfaction, especially in emotions. Or it could be that you have to shine the light in the eye to make it show up. But you'll find a pattern that'll either be weak or overfiring of the supraspinatus. And if you don't find it in the simple ways, in the clear, turning it off with autogenic inhibition, or then rubbing the Chapman's reflexes, turning it off with autogenic inhibition. If you don't find one of those positive, either weak in the clear or overfiring with the autogenic inhibition after the Chapman's reflexes, then you just go ahead and check these other ones to make sure you haven't missed something. Because there are all different patterns that could take place. Any questions about it? Yeah.
What do you have them sniff?
Oh, that's a good question. Yeah, what do I have them sniff? Sometimes I just have them sniff air. I have some, I'll tell you one of the things I use. Sometimes I use the oregano, the ADP by Biotics. It's got oregano. It's got a nice strong smell. As long as you're not allergic to it, it's easy to handle. I don't spill anything. And sniff it like that. And the trouble with using essential oils or something is they might have a therapeutic effect. And so might oregano, if they had some kind of a dysbiosis bug or something. But I haven't sniffed oregano, or I have some essential oils or perfume kind of things that I haven't smelled. But those things then start to run into possible conflicts of interest because they may be having some other therapeutic or potentially derogatory effect in case of a perfume if they're sensitive to aldehydes. So I usually use if it doesn't show up in the clear, and I suspect I usually use the oregano pill. It keeps me from spilling stuff on the floor. I have to change my carpet over and over again. Okay, so then we challenge with the cytokines and neurotransmitters. And with the challenge with the cytokines and neurotransmitters, we have the supraspinatus either weak or over, either in the clear, weak or over, or with therapy localization to the Chapman's reflex, weak, or over with rubbing one of the Chapman's reflexes, or weak or over with ipsilateral olfaction, or weak or over with light from the midline. But we find a Chapman's reflex that's involved one way or the other. And if it's weak in the clear, then we can therapy localize which Chapman's reflex negates the weakness. That's how we find it that way. So then the indicator muscle, we test. I like to use the lat because it's so convenient. We test with the neurotransmitter with the cytokine challenge to identify which substance is stressing the brain. So we therapy localize to the brain or supraspinatus Chapman's reflex that we identified above. So with the supraspinatus either over or under, indicator muscle weakens like a lat with TL to the brain Chapman's reflex with the neurotransmitter or cytokine. Then, from what we're talking about this weekend, we do a neurological or mechanical challenges when negate the weakness induced from the neurotransmitter cytokine challenge. So those are the four challenges that we just talked about basically. So here the Chapman's reflex is a review. Chapman's supraspinatus reflex that Dr. Goodhart talked about was the same one that Chapman talked about for the brain, although Chapman called it the cerebellum reflex. Other people called it the brain reflex. It's really more of a central nervous system reflex, I would say. I still call it the brain reflex because that's what Chapman calls it. That's what all the book calls it. And it's anterior over the coracoid process, and it's the anterior ones we're most concerned about. Rarely does the posterior one show up, but the posterior one's at the base of the skull down to the C1 lamina. It's the anterior ones we're looking at. That's the one for the brain. It's the same brain we call brain number 1 here. It includes the brainstem, at least the mesencephalon. It's right there over the tip of the coracoid process. Now there's this other one that I call cortex because it's a little higher in where it's located, and it seems to me that it doesn't seem to be related as much to the midbrain as possible, as much as it is related to the higher levels of the more higher cortical functions. In other words, this one here, that's on top of the superior surface of the clavicle, just medial to the acromioclavicular joint. It's right above the other one. This one will show up when there are more cortical issues, and here they are. That's why I call it cortex here. Brain CR, coracoid process, almost right above it. Depends on the patient's shoulder slope. The cortex on top of the clavicle, just medial to the acromion. It's going to be one of those four is going to show up. So what I want you to do then is I want you to check each other, test the supraspinatus muscles in the clear, perform autogenic inhibition, AI, on both to see that they weaken. Rub the brain Chapman's reflexes and retest autogenic inhibition for each supraspinatus to see if there is a overfiring, that would be the coracoid process, and then the lateral end of the clavicle, medial to the AC joint. And then if you don't find that, or if you do, smell through one nostril and retest for autogenic inhibition for the supraspinatus. So take a couple minutes now and do this, and note your findings because we're going to use them again a little bit later. Okay, so take a few minutes and do this to each other. The same procedures I was just talking about. Do you want me to demonstrate, or have you got it?
Got it.
Okay, good. Just ask a question. How many found one side or the other that showed a problem with the supraspinatus on one side or the other? Raise your hands. How many found it? So there are enough people here to do these workshops. What we may do later when we do these workshops is we may have to have you double up or triple up instead of just doing pairs. We have to get 3 or 4 together so everybody has a chance to observe the process. And once we're doing this too, remember we're doing these workshops, but we have not yet unswitched the person. We haven't made the corrections of injuries if they're present. Maybe it was happened the last time, in the last class or something. We were here, but we have to, before we determine exactly which side of the brain is involved and which reflex is involved, we really have to unswitch the person first. People could be backwards, it could be switched up. By the way, have you heard of the new group DAM? Speaking of switching, DAM, Mothers Against Dyslexia. So we get the superspecificity either weak or over, and then we're going to challenge the indicator. We have to then have that brain indicator positive before we can find out what neurological challenge will negate the weakness. This is a very important part of it, this neurological challenge part, but we have to have a challenge mechanism to deal with first. So we're going to challenge then the indicator muscle with the TL to the brain CR that was positive and a neurotransmitter or a cytokine. So what we're going to do now is we're going to test with cytokines. So those of you who had a positive brain reflex, we have, how many brought a cytokine kit with? Any bring a cytokine kit with you? A couple did? Good. And magnet maybe? All right, I have a couple of them up here, and I'm going to ask you, if we do this challenge, I'll ask you that if you get it from here, there are 2 of these kits. One's in a green box, one's in a yellow box. Put it back in the box that you got it from and the location that you got it from, or I will go crazy. So what I want you to do next then is to come up and check with, pick up a cytokine and a magnet. There are 2 magnets here, and some of you also have them out there, and challenge the Chapman's reflex to shut up with a neurotransmitter substance. Now, the ones I'd recommend you start with are glutamate and aspartate. They're the most common, and then work your way down the list in this fashion here, and see if you can identify a cytokine. In a minute, we're going to identify neurotransmitters. So just take a minute now and take the brain reflex that you just found and challenge with a magnet with a cytokine to find out which cytokine weakens. You don't have to find out which one strengthens today, just which one weakens. So let's take a couple minutes and do that to each other so we then have some people to work with. And again, if you didn't have a person who had a brain reflex positive, then work with someone who did, so you can all kind of work together and keep track of the same patient. Cytokines for just a minute. Then we'll do that, then we'll take a break. We do have those kits available. I think you know that, the major neurotransmitters by LifeWork Potential, and then also you can get them from them online or Michael Leibowitz's site online. Let's do the cytokines. Cytokines now. Now, when I test patients in the office, I test neurotransmitters. When I find a brain thing, I test neurotransmitters first, and I usually will find one. But in subsequent visits, I don't find the neurotransmitters after you've got them cleared. As I said, you go in there for the neurotransmitters. Usually they level out. They're not likely to show up regularly again unless the patient gets a big hit with histamine from an allergy or something like that. So then, I sometimes, after several times down the road, and I haven't found a neurotransmitter, I'll just skip right to testing the cytokines on patients. But initially, I test the neurotransmitters first, and supply the nutrients for neurotransmission first, and check that first with the patient. Then the next thing I do is after supraspinatus reflex, I'll check for the cytokines next. The reason I took the patient before and just tested with the cytokines was because she'd been here before and I thought she might have already had some of the neurotransmitters corrected. And so I just wanted to jump to the cytokines because those things do shift around a lot. But I usually check neurotransmitters first, usually glutamate and aspartate, and then whatever else they show, it might possibly show. And they may or not show neurotransmitters, especially if they have good nutrition and they don't have genetic faults. But if they don't show nutrition for a neurotransmitter, or if they do, the next thing I'll check the cytokines. And subsequent visits, the cytokines are positive, and that visit or subsequent visits, I'll check to see what weakens and then what strengthens. So that's what we're going to do now. Now, these are the cytokines that are most common ones. The Th1 cytokines are the most common ones to cause weakness of the indicator when you TL the brain reflex that's involved. TNF alpha, that's tumor necrosis factor alpha, interferon gamma, IFN gamma, interleukin 12, and interleukin 6. Anyone, just like neurotransmitters, anyone could cause weakness. But if I don't find one of those 4, then I'm going to check those that are the innate immune system cytokines. Now, interestingly enough, the innate immune system, the body didn't read the book. We try to compartmentalize the innate immune system and the adaptive immune system. These are Th1 cytokines, TNF alpha, interferon gamma, IL-12, but they also play a role in the innate immune system. So there are 6 major cytokines that we can look for the innate immune system. If I've already tested these and they're negative, and interleukin 6 is negative, interleukin 6 is also pluripotential. Could be Th1, Th2, could be an innate immune system cytokine also. It is an innate immune system cytokine. If I tested all these 4, the next 2 I'm going to check are from the innate immune system, interleukin 1 and interleukin 8. So if I don't find, this is the kind of order I do it in. So I'm going to have you do that, and we have those things available as well for purchase if you need them. But in fact, what I do in my office is I have the 1-ounce bottles that we put together that have all the 3 Th1 cytokines in them. I screen with that first because it's just quicker. And if that doesn't weaken, then I'll jump down to interleukin 6 and then the other innate immune cytokines. And I see patients who weaken on interleukin 8, enough to make it worth checking. But I check it after these. Interleukin 6 is common. There is the possibility, if you check with the bottle that has Th1 cytokines, has all 3 of them in, it's possible that you could not find it to work because it might be they would weaken on TNF alpha but strengthen on interferon gamma. And they're negating each other right there in that bottle. It's possible. I hardly ever see it, but once in a while I see it. So just mention to you, if you're using that quick screening test and you don't find anything, go back and check each of these 3 separately. But what I want to do now is take another couple minutes and check each other. You check for the neurotransmitters. Some of you already were testing the cytokines. The cytokines are in the green and blue box. Go ahead and check each other and see if you find cytokines, and then we'll take a break after that. And after we take the break, we'll see the patient, and hopefully she'll get it by then. But so go ahead and check for cytokines and write down what you've got because we're going to use these things later to recheck for these structural challenges. Okay, we're going to go over a couple slides, kind of review the whole procedure that we're going to do, and then we're going to demonstrate on our patient Mary Beth. And I'll introduce her in just a moment. the seminar topics are discussed in the context of the QA protocol, as you know. And QA is the outcome of 30 years of focused attention accommodating a physiologically based, basic science-driven neurological hierarchy for the ordered application of clinical procedures and techniques. Of course, you've seen that before. And it is a common clinical approach in all healing professions to look at patients' local complaints as the primary focus of the initial clinical assessment. The QA protocol revises this focus by insightfully approaching the patients presenting complaints as an integral part of their overall physiology. And then it assesses and treats physiology gone wrong in a systematically oriented, logical, efficient, and clinically rewarding manner. I think I said that. So most clinicians look at local problems, and then if they don't find the problem there, they step back and look systemically. But what we do at QA, we look systemically first. And we're dealing with brain issues where symptoms are related to the brain, then we actually reorganize the protocol a little bit to be able to assess the brain more efficiently. The order in which you perform techniques may be more important than techniques themselves. Our friend Dr. McCord said that, and I know he said that. So when would you then deviate from the QA protocol to perform the procedures discussed this weekend and in the entire Brain and Fire seminar series? It's when the patient's history and or symptoms suggest that the brain is the primary origin of symptoms and findings. And that's what we're going to do in just a minute. So in the Brain on Fire Session 4 seminar, procedures in the QA protocol, the procedures in the seminar are best addressed following clearing of injuries and switching, including small intestine, right brain, left brain activity, which is Brain on Fire Session 2 activity. And you will observe the supraspinatus brain activity will often change following these corrections. So some of you already had told me you'd seen that. So we'll won't even maybe check the brain activity until we clear those other issues with our patient, or we may, we'll see. So always correct IRT first, and then the other active injuries, switching, and K27 highlight, and then the right brain and left brain procedures, which we did in session 2. That's what we're going to do. Following correction of these things, of all these patterns, what we do is we then focus on Brain on Fire 1, where we go down to then use the TMJ as a diagnostic indicator and looking for mesencephalic stressors using different visceral disorders and or nutritional factors. So the TMJ as an indicator of autonomic endocrine immune activity will be the last thing we do. And we're going to do all this with our patient. So we're looking for this session at neurological stimulation factors, but we're going to go through the neurotransmitters, the inflammation, and the neurological stimulation at the end. We look for weakness of the muscle or over the muscle, and we'll use the indicator muscle with the cytokine and neurotransmitter challenges as an indicator of the different neurological corrections. So neurotransmitters, inflammation, neurological stimulation. We'll look for excess excitatory neurotransmitter, the deficient inhibitory neurotransmitter, and then the factors. That may well be cleared up in our patient. And then inflammation, cytokines and sources, and nutrients for cytokine modulation. This changes all the time, so we may well see that. And we look at neurological stimulation. Does the brain need excitation or inhibition? And if so, in which pathway or pathways? So the whole procedure is that we are going to correct all injuries first, then correct switching factors, K27, hyoid, and small intestine. Then we correct right brain, left brain patterns from Brain on Fire 2. Then we'll test the supraspinatus, right and left, for weakness in the clear, doesn't weaken autogenic inhibition, and so on. Then we'll find out which supraspinatus or brain Chapman's reflex will cause the ipsilateral supraspinatus to not weaken if it was weak, if it was strong in the clear. We'll find which brain reflex needs to be used at the test. So therapy localized to the supraspinatus brain or cortex, Chapman's reflex with neurotransmitters causes indicator muscle to weaken. We find the neurotransmitters that negate the weakness and the nutrient factors to strengthen it. Appropriate nutrients will negate the weakness. Then, once we found that weakness with the neurotransmitter, we'll check for autonomic, sympathetic or parasympathetic factors against that neurotransmitter. Using the eyes, far and near, the TMJ, protruded and retruded, we'll treat the organ in question. But we won't quite treat it yet because we're not going to treat the organ until we also test the cytokines. Then also, we will check for, if we don't find the autonomic factor, we'll identify other afferent factors that negate weakness, the lateral flexion, the opposite semicircular canal, and the immune system factors. But again, we won't treat this until we've also found out what's affecting the cytokine challenge, if there is, if both are present. Then 5, we get to the supraspinatus brain or cortex Chapman's reflex with the inflammatory cytokine weakens an indicator muscle. We then find the cytokine that negates the weakness. We then find the nutrient that supports that strengthening cytokine. Then we check autonomic to see what will also negate that weakness, but we don't treat it yet if it's present until we've checked the neurotransmitters as well, which we may have already done. And then we identify the other afferent factor that negates the weakness, the lateral flexion, the semicircular canal, or the immune system. And then when we found those factors, they need to be treated for both what negates the neurotransmitters and what negates the cytokines. And they are very often the same. Then we'll go ahead and treat them. When treating the structural problem or the neurological problem, note that injury recall technique has an excitatory effect on the cerebellum and the central nervous system, that acupuncture head points, set point, LQM, location quality memory technique, and emotional techniques, emotional tapping, have net inhibitory effects in the central nervous system. That's something that can play a role at certain times. We'll go over that again later as well. So the last thing we do is we treat and supplement as indicated. So we're always going to do switching first, Brain on Fire, right brain, left brain, from Brain on Fire 2 second, and Brain on Fire session 1, TMJ as diagnostic indicator last. So let's do a procedure demonstration. I'd like to introduce you to Mary Beth. There she is. Thank her for being here. Mary Beth is a patient of both my brother John's and mine. She's a very accomplished woman. How many books have you written? Just one, or have you written more than one? You've written 2 books. She's an author, and she's done, I won't go into her whole personal history, but she's a very kind of impressive woman. And this is her history. This is not her complete history. She's going to fill us in a little bit on it. She has a lot of fatigue and exhaustion. She says her eyes feel like sandbags. That's still? Yep. Brain fuzziness, as you describe it. Memory issues like not connecting the dots. Get body pain. How's the body pain doing?
Feels at times, but the the level of my pain has gone down maybe 1 or 2 notches, and then it goes back up. It vacillates, but there's been some improvement.
Okay, it's mostly in the lower limb still?
Yes.
Okay. And it's worse in the morning
And from walking,
and if walking, okay? You get headaches behind the eyes still? Okay, have them now?
I do.
Okay. And how about the spot behind your ear? Still there?
It's really weird. About a week ago, it started clearing up, and around the time it started clearing up, I started getting this red spot right here. So my ear now is okay, and this doesn't hurt, and I can disguise it with makeup, but I know it's there.
Okay, so the point of this is she's got a skin lesion which was behind her ear, and now it's actually moved, but it's still something going on that's unusual. And where is it? It's on the left side. So keep that in mind, okay? Lots of allergies, grains, dairies, a number of others. Now, the left brain in general increases immune system function. The right brain in general decreases immune system function. I always have to decide which part is being increased and which part is being decreased, but in a very general sense, a person who has a problem with the right brain will have a problem with keeping immune system functions down or intact, because the right brain inhibits immune system activity in a general way. So if a person has a lot of allergies, you would tend to think that maybe they had a problem with the right brain, just off the top from the history, okay? If a patient has a strange lesion on their skin on the left side or moves around or something, you'd think left side, you'd think right brain, okay? So just from a little bit of history, we're starting to maybe focus on which side of the brain we might think might be involved. The other symptoms don't necessarily give us an indication of where to look, but we know from the symptoms we're going to look at the brain, so we're going to employ the brain on fire protocol in lieu of just the quintessential applications protocol. So she has a bunch of supplements she's taking. These are some of the ones. I did put them all down there. I didn't put them all down. Ginger, blackcurrant seed oil, skullcap, product by Kaelin, and Tenzyme Forte for the digestive, the enzymes, polycosanols. So these are just some of the nutrients she's taking, which are to resolve, designed to resolve both immune problems from inflammatory activity, as you see, and then maybe some other digestive problems, and polycosanols for also maybe anti-inflammatory effect, but also for cholesterol metabolism can also be part of that as well. Polycosanols are one of the things that helps to break down cholesterol. So we have this stuff that makes up the history, but maybe you would have to add a little bit. Can you come over here? Yeah, we're closer to the microphone.
Okay.
Okay.
I don't have to yell as loud.
Yeah, okay.
I've been on the Supreme diet, the leaky gut diet, extra to the nth degree for about 4 years. And since I started it, I have improved really remarkably. So I'm grateful for that piece, but now we just feel like we're on some kind of a plateau. Another thing that I notice that I have quite a bit is a lot of coughing at night and wake up with heartburn. And if I bend over quite, to pet the dog for a bit, my heartburn will kick in pretty quickly. What my brain did this morning was just weird, but it's different every day, but similar to this. I have a tiny little pantry, and in the pantry I have a bag with plastic bags in it, so I go to open it and the bag moved, and my mind thought, oh, the cat is in the pantry. Where's that coming from? So it does weird things like that pretty much throughout the day. I think that pretty much covered it.
Okay, and you have a little headache right now? Little headache or big headache?
Little, it just kind of lurks throughout the day, comes and goes. My eyelids are really tired. I'd love to take a nap.
Okay, so the question is, are eyelids tired because there's some brain fatigue, or are eyelids tired because their eyes are tired and you haven't done any extra eye work today or anything?
Nope.
Okay, so it's probably part of what we were talking about earlier about brain fatigue. So what we're going to do is we're going to run her through kind of some testing and some of the same things we do in the office. So first, I'd like you to stand up here and look at your posture, please. Just face that way. I always want to look at your posture first. Okay, that's good. Now, hold on right there. Brought myself a little note-taking sheet. All right, so what I'm going to ask you to do is I'm going to ask you to walk back and forth across here, and don't trip on that wire, and just walk over there and turn around and walk back, please. And walk back this way. Okay, now walk back the other way and hum a tune. Okay, good. Now walk back this way, but when you walk back this way, say the months of the year starting with January, but every other month.
January, March, June, August.
Okay, okay. And then stand here, walk back the other way, and do some kind of math counting backwards from 100 by whatever number you wish.
100, 99, 98, 97.
Okay.
96.
Okay, that's good. Okay, so that's good. So we can see that when you do the left brain activity, the gait changes. Okay, gives us one thing to measure. Okay, now I'm going to ask you to stand over this way a little bit more, maybe right about here, like that. Put your feet close together. Close your eyes. Okay, she goes to the right. Okay, open your eyes. Stand on one foot. Okay, and stand on your other foot. Now stay on your left foot. Get steady and close your eyes. I got you if you fall. Start again, stay on your left foot. And then with your, when you get steady, close your eyes. Okay, okay. You stay on your right foot, please. Okay, just grab it on after about 6 seconds. Let's do the left foot again. Do you have another chance at it?
Left foot.
Okay, left foot, get steady, and then when you then close your eyes.
That's another thing I can't keep right and left in my mind. Okay.
Okay,
Left
so,
foot.
yep.
Okay.
Yep. Okay, one more time on the left foot. So she was doing about 6 or 7 seconds, actually getting a little bit less. About 5 or 6 seconds that time. So do the other foot. You steady, close your eyes. And one more time on this foot. So that was about 6 or 7 seconds before. So it's actually almost fatiguing a little bit as she does it longer. Okay, just make note of that. You write this down. Okay, now, sit right up here for me, please. And repeat these numbers that I'm going to give you. 9231796.
9, 3, 2,
Let's try another one.
1. Okay.
Okay, I'm sorry, I didn't mean to interrupt you. Okay, you have more time. Okay. 4723618.
4, 7, 3, 6.
Okay, let's try another one.
Okay.
7329448.
Oh, I forget the first number. 9, 7, 2, no.
I'll give you another one. 8635126.
8, 3, 6, 5, 1, 2, 6.
Okay, and we'll try one more. 4935781.
4, 9, 3, 5, 7, 8, 1.
Oh, very good. Okay, good. So you got that. So it's a little bit more struggle with the left brain than with the right brain. Okay. Okay. Now, what I'm going to do is I'm going to treat her without checking which brain circuit shows up, because it will change if she switched or anything like that. So I'm going to treat her first with just the protocol we talked about, which is on the summary of the one page that has all 4 sessions. It's the session 1 through 4 at the top. And where did I put that one? Yeah, abbreviated procedure summary. That's what we're going to do. So first I've got to find a weak muscle. Would you lie on your back for me, please? Put your head up here. Yeah, let's first stand up, Maribeth. I'm going to move the table down a little bit so that they get a better view of it. Okay, lie on your back for me again, please. Is the head okay? Okay. So I'll do a TS line, see if we can find a weak muscle. Put your leg straight down, please. Lift this leg up in the air. Resist as I push down. There's a weak psoas. Lift up here, please. Resist. Push up hard. Again, push hard. There's a strong psoas. Hold this leg up and out to the side. Resist as I push in. And let it relax. And then this one. So we have strong tensor fasciitis, but we got a weak psoas. Now, let's try to find another weak muscle. Hold your arm here. Resist as I push back. And this one here. Resist. So weak pectoralis major sternal. So I'm going to use this muscle to do autogenic facilitation to see if there is an IRT necessary. I'm going to push in this muscle. Push hard. And it's strengthened, so there's not an IRT injury pattern we have to worry about. Now, there could be a weight-bearing one, or with her symptoms she had, it would also maybe suggest the possibility of a hiatal hernia type of problem or reflux. So she could have a hidden injury recall pattern, which could be related to a weight-bearing problem with the pelvis, iliolumbar ligament, which is supported at this point, or the sacrospinous sacrotuberous ligament, which is supported at this point. Or it could be the position she's in is there's a hiatal hernia pattern, which may not be obvious from this position. But what we're going to do is we're going to check for that because of her symptoms she had. Push straight across. And then I'm going to challenge here, push. And sure enough, it weakens. Let me get a little better challenge on it. Push hard, please. Okay, so now my question is this an injury recall type of a weakness? And if it needs to have injury recall technique done when I do the hiatal hernia technique, it will cause, the weakness will not respond to autogenic facilitation. So injury will cause autogenic facilitation of the pectoral clavicular, and not strengthen. Push hard here again. Sorry, okay?
I'm feeling the indigestion come.
Okay, I'm pushing it up, that's why. Push hard. Okay, so it's actually, autogenic facilitation doesn't strengthen, so I'm going to do hiatal hernia technique with injury recall technique. Now, let your leg go out this side. We'll just measure one more thing. Far as it'll go. It's pretty good. Bring it back, please. And measure the range of motion here. Pretty good, pretty symmetrical too. Bend your knees up for me, please. Okay, now I'm going to pull this down, okay? Take a breath in and let it out. Okay, take another breath in and let it out. Take another breath in and let it out. Okay, just breathe normally. I'm going to hold it there for a second. Okay, good. Now hold your arm up again. You put your legs down again, please. Push up. Okay, so I'll pull it back down because I don't want to push it back up. It doesn't challenge anymore, but I'll still give it a push in the right direction anyway. Lift your leg up, knee straight this time. Resist as I push down. And we still have a weak psoas. Hold this one up here. Push. And a weak pec sternal. I'm going to do allogeneic facilitation, push, and it still strengthens. I'm going to pull this down one more time after I push it up. Just breathe in again. Let it out. Okay. Because I pushed up with a challenge and initiated that again a little bit. All right. Now, the next thing I'm going to do is to see if possibly she maybe has another injury somewhere but might be weight bearing. So sit up for me, please. And that's good. You can swing your feet around like that. And usually if it were going to be a weight bearing injury, it'd be iliolumbar ligament or maybe a sacrospinous or sacrotuberous ligament. But let me just check that. Because you have the weak psoas, I'm going to check the iliolumbar ligament. I'm going to rub into the iliolumbar ligament at L5 and challenge the talus up. Hold your arm by your side, please. Pull in. Resist. Okay. It's okay on the right. I rub into the iliolumbar ligament and challenge on the left. And that seems to be okay. Okay, please lie on your back again. Now put your fingers on K27 here and here at these points. Push your legs straight out in front of you. And push your legs straight out to the side. Resist as I push in. Now put the backs of your fingers in the same place, please, and bite your teeth together. And push your leg out. Okay, so there's a dorsal K27. I'm going to rub your jaw here. And bite your teeth together again and push your leg out. And here. Push your leg out. Okay, let me try this again. Keep your teeth together. Push your leg out. And then on the side here. And push your leg out again. So it actually shows if I rub the right TMJ, I was a little far anterior at first. Yes?
In the notes, it suggests that step 9 and step 5 and 6, with evaluating steps 5 and 6 with lateralization of the jaw, be potentially done before step 9. Does it make a difference?
Yes, does it make a difference to do step 9 before step 5 and 6? It does in this case because it looks like there's a tooth problem which will affect the jaw lateralization. That's why it's sort of interchangeable. If you've got a tooth problem, the lateralization of the jaw won't show up. So I kind of chose to do it this way. Sometimes steps could be interchangeable because one sometimes is more important than the other, but in this case I'm doing it because of looking so I can check the lateralization of the jaw in a minute. Okay, so put your fingers on your jaw joint right here. And I'm going to test a strong muscle, just the one. Resist as I push down. And now, tilt your head back and push against me and bite your teeth together. So when she puts her head back and touches the right TMJ with the teeth together, it weakens, not with the teeth apart. This confirms to me that there's going to be a neurologic tooth type problem or some tooth problem. Any teeth bothering you on this side?
No.
I didn't bring any gloves, so what I'm going to do is keep your fingers here. And your hand get a little far away. Keep it right there. I want to get my fingers in between your hand and the jaw. Okay, so tilt your head back and bite your fingers together. Push hard. I'm going to rub through the lip. See if I can rub on an area of a tooth that might show positive tooth involvement. Let me see if I get it this way. Thanks. So just this position with her head back is causing some of that reflex again. Push again. Sit up for me, please. We'll do it sitting up. Now, let me pull that down again a little bit. Okay, I found it right back there. When I rubbed on this part of her lower mandible area over the teeth that negated the weakness that we had from her touching the jaw, put your finger inside your mouth on that last lower tooth right bottom. Yeah, last little more right there, but on the gum line, at the gum line.
Okay.
And instead of on top, kind of on the side.
Okay.
That's it. Hold your arm up here. Resist. Tilt your head back, please. Push hard. Okay, let your head stay neutral. Push hard. So it's a set point for the tooth. Keep your finger there. Let your arm relax. I'm going to tap here 100 times. This is when you need a 20 or 25 seconds to do this. So you need a 20 to 25 second joke. How many librarians does it take to change a light bulb? Look it up. That should be what the things. Okay, hold here again. Push hard. Okay, now put your fingers on your jaw right here again, and tilt your head back and bite your teeth together. Push hard. Okay, so that negated that. Please line your back again.
Forward.
Yeah.
You had mentioned that something indicated a tooth problem on her. What do you think that was?
When she had dorsal K27 PL, it's going to be a TMJ problem. It may be a tooth or just a TMJ problem. It turned out to be a tooth problem because when she did IRT to her TMJ, it was negative unless she put her teeth together. When she put her teeth together, I knew it was aggravating a tooth imbalance.
I mean before that. When Gary asked
When he asked that question, I've treated her before. It's sort of interchangeable. I decided to go this route.
Okay.
Yeah, I mean, it's kind of, you might say guesswork, but I've treated before. Put your legs down, please. Put the backs of your fingers here and here. And I'm going to test this leg here. Push your leg out to the side and bite your teeth together. Now, cross your hands in the same places and bite your teeth together. Kind of bridge one over the other, getting teeth together. Okay, that's good. Now, hold up here. Put your fingers just like this with regular K27, because K27s can be interchangeable. Push your leg out to 3 different types, okay? That's negated. Get your hand come up like this. Push, negative, I should say. Push here. Check the hyoid. Okay, now let's check her TMJ. for lateral motion, because I've gone through the other switching factors, so I'm going to check for small intestine. What I'm going to ask you to do is to move your jaw right, left, back, and forth. Push hard here. So you would say, okay, that's probably going to be negative. Okay, I'm going to teach you something a little later on this afternoon that will amplify this TMJ motion as an indicator for what we saw in the first session. It's got to do with something I mentioned in the first session, more or less in passing. I'm going to have her do other motions which are right, left in nature. Turn your head right, left like you're shaking your head no, please. Resist hard. But that weakens her. Make your eyes go back and forth, right, left. Push hard. And that weakens her as well. Let your pelvis roll back and forth, right, left, just like your head was. About 3 times, and hold here again. Resist. And that weakens all these compartments, the pelvis, the eyes, the head, neck. They weaken, but the jaw doesn't. Make your jaw go right, left, back and forth again. And that seems curious, and so it is curious. And what it means is there's something that's throwing her body compartments out of sync, and the one that's out of sync right now is the TMJ. So I know from experience that this is generally a set point for a TMJ muscle. Usually, could be IRT, but usually it's a set point. It's usually for the internal pterygoid. I'm just going to rub behind the internal pterygoid. And as I showed you before, when you're looking for a set point, if you do a patient-started test, resist, it'll be strong, but when you do the rub over the area of set point, push across again, it'll weaken, so it turns out it's on her left side. I'll do the same thing on the right side, push across. So she's got, behind her posterior mandible, probably at the internal pterygoid, need for set point technique. Put your fingers here. And that's not surprising, seeing that following the tooth involvement. There's sometimes adaptation to TMJ muscles. Resist as I push. Okay. Now, keep your finger there. I'm going to tap here 100 times.
45-second joke.
I only have one. I have another one, but I told it last time. Okay. So, keep your fingers there again. We'll check that. Tap again. Push hard. Take your hand away. And make your jaw go back and forth, right, left again. And push hard. Again. Push hard. And that weakens now as well. So again, right, left with your jaw again. Put your fingers right underneath there. And I'm going to get on the more bottom part of the internal pterygoid. Resist. Now, it seems to be okay. It just wasn't weakening quite as much as I would have wanted. But go right, left again with your jaw. Push hard. Yeah, it weakens. And now the head, right, left again, and hold hard. And resist hard. So they all weaken now. I mean, I assume they all weaken because they usually do when you get the one back in sync. Touch the quadriceps reflex. Touch the reflex point right here. And make your jaw go right, left, back, and forth again. Just your jaw. Just your jaw. Push hard. Okay? So there's a small intestine problem like we suspected. And bend your knee up, please. And put your hand right there. Make your jaw go right and left again. Push hard. And it's primarily the upper small intestine reflex, not the lower one. Put your hand down, please. Let's have you sit up again. We can do some of the sitting. So now, I want to see what is the nature of that small intestine problem. Is the nature of that problem a Th2 type reaction or Th1 type reaction? Probably food. So touch your fingers to the lower border of your ribs right there. Use the other hand if you don't mind. Hold your arm in. Pull hard. Touching the quadriceps reflex. Now I test with the interleukin 4, and it weakens, so I know we have a food reaction of some sort there, or a non-living reaction. Anyway, it's probably food. And she's got so many allergies. Where do you start? You know. So we could go, if we did not know what she was allergic to already, we could test foods and find out what they were right now. But we know. So what we're going to do then is we have to reset this. Well, I don't have all the foods to test, but it's okay. Because one of the things that we can do, and I went over this in the first session, is you can actually use a neurotransmitter to challenge a Chapman's reflex. And if there are multiple factors, like for foods, multiple foods, you can find one neurotransmitter and it'll usually correct all the different food reactions. So you don't have to do each food at a time. Now, maybe you remember I went over fairly quickly, but you can use a neurotransmitter substance, treat IRT to, say, quadriceps reflex, and it will correct pretty much all the foods that are reacting. Could be more than one neurotransmitter. Most of the time it's just one. So I'm going to challenge then, and I'll do IRT instead of with the foods to her Chapman's reflexes. I'm going to do IRT to her Chapman's reflexes for the quadriceps for the small intestine with a neurotransmitter substance. This has to do with the effect of the neurotransmitter impacting the immune system. Okay. So put your fingers right here again. Now, this could be any neurotransmitter. So you can take your guess, but because she's got so many allergies, I'm just going to check histamine first. Yeah, so there's another reason to check the histamine. Good observation. The only problem is then I have to find the histamine, which I did. Okay, so touch there, and pull hard again. Resist my pressure. And it is histamine. So I have histamine drops in my office, histamine homeopathics that are I can use. I usually try to treat with the substance on the tongue, even though I test with the magnet. But because I don't have those here, I'm going to treat her with the magnet using the histamine challenge. And please touch your fingers along the lower border of your ribs, right up to the middle. And then I'm going to do like this, and then ask you to move your fingers out to the side a little bit. I'm going to cover, okay, all along here, and all the way out farther. And a little farther. All right, that's good. Now touch here again. Hold this arm by your side. Pull your arm in. And that corrected the histamine factor. And that will usually correct the challenge factor with the cytokine, the interleukin 4 in this case. Pull hard. Good. And now, if you please line your back again. Put your feet down. And make your jaw go right, left again. Push hard. Now, I know when you do the pec clavicular test, you're supposed to have the hand on the shoulder, but I'm doing it so you can see better. I know I can test it. Okay, it's not the hand on the hip. I know that's not the best way to test it. But okay, rotate your head back and forth. Resist. And now move your eyes back and forth, right, left. So it's corrected all those things. Roll your pelvis back and forth, right, left. Good. Push hard again. Okay, so let's see where we stand. Now what we've done is we've gone through just all the preliminary procedures. And one of the things we fixed with small intestine with food allergies, and that's always going to have right brain, left brain implications, as did the switching with the tooth and so on, and the jaw. We found a jaw thing in there with a set point. Let your leg go out the side again for us to go. And that's the same. Bring it back here, please. And then here again. Actually, what's happened now is there's asymmetry. We've got a little farther on the right one, but the left one hasn't changed. So we smoked something out anyway, okay? And stand up for me, please. And go ahead and stand for me again, please. Now I'm going to ask you to walk over there in that direction and say the months of the year, every other month starting with January again, please.
January, March, May, July, September, November, January.
Okay, come on back here. And that's good. So it's a little bit better, okay? And walk back over there again and count backwards from 100.
100, 99, 98, 97, 96.
So there's a perception of improvement there. Okay, we can all perceive that. Okay, come on back. So just see why we have to do that first. Sit up here, please. We have to do those switching factors, as I call them, as a group of injuries and so on. If we don't do that first, then we haven't cleared the playing field for getting a clear picture of what's going on in the nervous system. We've already fixed a few things by just doing that relative to brain activity. Now, do you have any, how's your headache?
It's still here.
Same?
Maybe a little less.
Okay, it's basically not, she hasn't gone away. So I'm just assessing stuff as I go along just for our academic interests and to try to make her have the best response she's going to get. So now what we can do, having cleared those things, we can now go and we can check for the supraspinatus pattern. So we have to check both supraspinatus and we have to decide which side is involved, okay? Now, it's possible to have both sides, but we're going to check them one at a time. I'll check the left one first. Hold your arm out here, push against me, please, straight out toward the side. I'm going to bring your arm in a little farther, that's good, right there, push. And it weakens in the clear, push. I'm sorry, it's not weak in the clear, it weakens when I do autogenic inhibition, and it weakens when I do autogenic inhibition with rubbing both of the Chapman's reflexes. There's nothing going on there. Hold out here, push out to the side hard. It's strong in the clear, it weakens on autogenic inhibition. I rub the brain reflex on the right, it weakens. I rub the cortex reflex on the right, and it doesn't weaken. So we don't have to go any farther, we don't have to do light or olfaction or anything else because we found the reflex we want to use, the left cortex reflex.
Would you, prior to addressing this particular issue, do the brain on fire session 2?
Yes, I'm going to do the brain on fire session 2 next, but yeah, thank you, because I wanted to introduce just the fact of what we found, and then I didn't want to do it earlier on. It might change again.
Right.
I just didn't want, so I'm going to introduce it because I want to show the importance of doing it in the right order. So line your back for me again, please. Let's see if we have any of the muscle weaknesses again. Lift your leg up in the air, please. Turn your toe up. Resist as I pull. Psoas is a little strong, but still somewhat weak. Hold your arm up here, please. Resist as I push back. The pectoralis major sternal, however, is strong. Let's just see if it maybe switched. Push. No, they're both strong, so we have a weak psoas. Now we're at the point where we've cleared all the switching factors, and we can start to evaluate the right brain, left brain things as we were saying, but we saw that she had a right cortex issue. We're going to now do what we did in session 2. We're going to evaluate the psoas weakness with right brain and left brain activity to decide if there's an immune or endocrine immune or a nutritional factor that has to be corrected first. Lift your leg up, please. Resist as I push down. Hum a tune, please. Push up hard. Now keep humming and push real hard. Hard, 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 hard. So it doesn't strengthen with either so-called G1 or G2 testing, type 1 or type 2 testing with right brain activity. Count backwards again, please.
100, 99, 98, 97, 96, 95.
With regular type 1 testing, it doesn't strengthen with left brain activity. Count backwards again, please.
100, 99,
Now push up against my hand as hard as you can. Hard, 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 hard. Okay, sorry. But it does strengthen with type 2 testing, with so-called G2 testing we used to call it. Okay, patient-centered testing. So what I'd like you to do now, that we have two things to assess when it's type 2 strengthening. One is immune system by swallowing, and the other is certain nutrients which are related to making fist with the right fist and hand, because it's the left brain. Let's do the fist and hand first. Make a fist with your right hand and foot, okay? And push. And it should cause a G1 strengthening or type 1 strengthening. It doesn't. You can swallow again, please, now. The swallowing does strengthen. Well, look at the... Let me see that for me, please. So look at the problem. She's got this hiatal hernia type of reflex thing, which always is going to disrupt the swallowing mechanism, but maybe she's partly got it because the swallowing mechanism is disrupted. You see what I'm saying? It's like, is it a chicken or the egg? I don't know, but the swallowing strengthens. So we're going to fix this, and maybe it'll have we'll see if it has an effect on the big clutch 7 lying down later. All right?
Just getting choked up over it.
Okay, so our difficulty is now to try to test her in the supine position. So what I'm going to do is something that's a little bit awkward. I'm going to test her psoas, which is weak, in the upright position, and we'll test for some, because now what happens, when you swallow and it strengthens, there's going to be a problem with the swallowing mechanism on that side, but it's going to mean there's a cytokine issue. And when the left brain strengthens, it means the body needs more of some cytokine. We don't know which one, but it needs more of some cytokine. So we got the right psoas weak, so I'm going to try to test it with her sitting like this just to make it easy on her. That's okay. Lift your leg up here and push up toward the ceiling. Okay. And now, this is albeit a little awkward, but I'm going to test her with interleukin 10 is the first one I got my hand on. Lift your leg up. Push up hard. And it doesn't strengthen interleukin 10. So I'm going to test her then with interleukin 2 plus transfer growth factor beta, which would be something we would find strengthen if she needed more T regulatory cells, regulatory C cells. Lift your leg up again. Push hard. And in fact, she does strengthen on that. So she needs more Treg cells. So now I believe I am confronted with the same issue that I was the last time we had a seminar to try to find what she needs to help support the Treg cells. And I don't have everything here. I didn't bring one of them, but we'll try anyway. So then what we're going to do is we're going to take the list that says nutrients. Where is it? It's the cytokines nutrients list.